command support.
Good afternoon, everyone. Good afternoon. I extend a very warm welcome for the inauguration ceremony of ICSE's International Perinatology Conference. I, Dr. Chairperson Perinatology Committee, would like to extend a very warm welcome to each and every. Before we proceed with, just like to say a few lines that this conference is indeed come true. Foxy in a culture of work, academics, and of social work. Our committee has been 100 CMEs and term labor, and it is Foxy through Foxy gave us an idea that why not dedicated 2-day interventions focusing only on, because as we know is the leading cause of infant death and the second leading death for babies below 5 years. And in this endeavor, for committee, Dr. Gupta, Chandra Doshi, Dr. Parag Biniwale, they advised us, and of course, leadership of Dr. President Alpesh Gandhi sir, President Dr. Archana Basse, Dr. Anita, and Dr. Jaideep Tang, we could realize this program. And come true, Dr. Chairperson PSC committee, and Dr. Priyankur Roy, Regional Coordinator Perinatology Committee, ahead with his enthusiasm, ideas, and that is how this conceptualized. This activity. Yesterday we had a packed active day with social program. We had a virtual walk, there was quiz competition, various kids acting Foxians, and paper presentation. Consultant Foxians more than were judged and presented. welcome you all for this today's day. Again, we have signed oration with orations and keynote addresses, debates and panel discussions. Before we start, I would like to thank the dignitaries on the dais, esteemed office President Foxy Gandhi. Sir, thank you for encouraging us for this conference. Dr. Shanta Kumari Palshetkar, Dr. Atul Ganatra, Dr. Ragini Agarwal, Dr. Jaydeep Tang, Dr. Sunil Shah, Dr. Parik, and the ICOG, Dr. Mandakini Meg, Chairperson ICOG, for granting us ICOG for so many of our perinatology webinars. Dr. Parul, Dr. Parag Beniwale. We have a chief guest, member of parliament, Tai Sure. We also have honor Dr. Ashok Devraj, NNF, and invited guest Dalwai, Joint National Secretary, IAP. I would like all the invited dignitaries come ahead for a prayer and lighting of the ceremonial lamp. Thank you, everyone. And now invite Dr. Alpha sir to give the presidential. Sir is President Fox, and sir is president. He has read academics and social work in the COVID. He is in Foxy was the first association under the leadership come up with guideline GC how to manage pregnant times. He has done social work right from organ donation to tree plantation, scientific postgraduate paper presentation on over 2 days, and tomorrow big event of violence against, which is a huge amount, tremendous, which is being done for tomorrow's event. Sir has truly, with academics and social work, to the masses, to all the gynecologists all over the country. Sir was vice president 2013, and it is leadership and guidance and encouragement that we chairpersons are able to do such kind of work. Welcome, sir.
Thank you, Dr. Vaisali, for the generous introduction. Honorable Minister Supriya Suleji, guest of honor Deorari, Dr. Samir from ICOG chairperson Kini Meg, Dr. Chandravati Madam, Dynamic Secretary, Dr. Jaideep Tank, very active committee chairpersons, Dr. Chavan and Dr. Kalyan, esteemed faculties, friends. A very good of you. I welcome to on behalf of Foxy. Would like to take your 1 minute about Foxy. Is the Federation of Obstetrics and Gynecological Societies of India. We have 158 societies like and nearly 1,000 gynecologists practicing across, probably making it one of the largest organizations of fertility across the world. We are taking care of nearly 50% of India from reproductive adolescent age to teen reproductive age, menopause, geriatric age. Primary mission is to reduce maternal and neonatal morbidity, short-term and long. Friends, I workshop on pre conference on preterm birth, perinatal particularly. Nothing is as frightening or new mother than watching a baby later connected and wires and all was born too soon or wait. A low provides an un the best of neonatologists have it not just survive but thrive. WHO defines preterm birth alive before 37 weeks of pregnancy are completed, and we all know that it is a leading worldwide for children below 5 years of age. While many preterm babies in high income countries and in low countries, a lack of adequate newborn care inputs puts many preterm babies at risk. Of course, improvement in India also, and we have now also improved in many of the states of, but still we are worrying for the morbidity aspect also. Survival is not only survival and the also be thrive, so that in 2000 10.6 of all globally were preterm and approximately 1 million deaths in 2000. Three quarters of prevented with current cost effective. Unfortunately, highest number of preterm birth in the world with 3.5 million preterm, and during this difficult time again across the world increasing, somewhere it is around from 20 to 25%. As obstetricians, we have a chance to break predicting at risk for preterm, observing minutely for the signs that can be counseling the patient so that the importance of these early measures is and compliance is achieved. Cases that have already crossed stages and then bringing these fetuses safely to term, sense of the management of low birth baby and many others. This conference aims. Foxy believes in strong partnership, believes in impact partnership, and probably COVID-19 pandemic has taught of us and indirectly opportunity to all of us to work to in such platform. We closer to each other, and I am happy to see we have participation from NNF, from IAP. So see all of us working together for such. Let us work together with treatment of care of women and neonates and children. I hope we'll have as much learning participating in this work conference as Dr. Vaisa and Dr. Kalyan had organizing it. Once again, congratulate perinatal for this excellent work, beautiful scientific program, inviting so many eminent faculties. I wish grand success conference. We are thankful to all the eminent faculty and representation from different, and we wish. Thank you very much for the. Thank you.
Thank you, sir, for those and for guiding us so well. And you always encourage. Thank you very much, sir. Now I would like to invite our guest of Ashok Devrari, President NNF, and sir was very kind enough. I know he had a very busy schedule, but he agreed to become honor for our program because solely deals with premature, which an obstetrician and a neonatologist is required for the optimization of for the mother, but for the neonate. Why, sir, it's indeed an honor to have today. Sir is President NNF, Professor and Head of Department of Pediatrics at WHO Collaborating Center Research in Newborn Care, Delhi, the Chairman Skills and his Strategic Global Adaptation Newborn Care. Sir has awards and orations to his credit. Sir.
Thank you. First of all, Alpesh, for giving the opportunity of joining this group, and my special to Member of Parliament, Mrs. Supriya, Madam, and Madam Chandra is just like at AIMS for the last now more than 40. So Dr. Hingo Rani, you are, and Kamal Bakshi, you know them well. I think things have changed now, doing newborn health and saving premature babies with intact survival. What we know is the investment to come into improving labor and delivery room care, and government implementing Lakshya program in a district hospital, and is the most crucial period where if we are able to one care, labor delivery room care, we will be 41% of newborn deaths take place all due to related to labor room care. And we also, if we start doing investment for saving small and sick newborn babies, be able to save another 35% of newborn deaths. So that means one of birth and taking care of small babies will save 5% of preventable deaths. To this, it has to be a among the obstetrician, midwives, pediatrics, and the NNF individuals working together with, and then we have to provide high quality care to the woman at the time of birth. We know simple 5 practices need to do impact for saving small sick babies. One is use of antenatal corticosteroid. If a woman is delivering below 34 weeks of age, make sure antenatal corticosteroid complete course is given, 50% mortality and 40% risk of RDS in the baby. Second practice, which has to be dependent on obstetrician, is skin to skin care at the time of birth. Know that doing skin to skin care birth will initiate early initiation of breastfeeding, which impact on saving newborn deaths by nearly 20%, 22%. Skin to skin care at the time of birth increases the chance of exclusive breastfeeding to 3-folds at 6 months of age. Huge benefit. The third practice which obstetrician need to do is cord clamping. Even more than 1 minute up to, because it is shown that preemies will have less risk of IV, and then on top of more blood, stabilization is babies. Risk of anemia at 6 months in the baby. So delayed. The third practice which the obstetric practice in labor and delivery, initiation of breastfeeding. We need support from the nurses, midwives, and our messages have to be very clear. Breast milk saves the baby. Mother must express the milk and give. Babies can be fed through the tube or a spoon. And Dr. Chandravati, madam, things have changed so much. 85% are born after 32 weeks. They are above 1.5 kg. They don't need technology and ventilation. They can be saved by doing care. They can be saved by giving. They can be saved by just doing and keeping the labor room clean. Because babies catch infection from the labor delivery room. This is what. In addition, involving family, because we have less nurses, nurse, family, and then the mothers have to be kept in the hospital, which has to be given, involving and getting care for the preterm baby. We are moving to now next. Travel is not a problem, but they must. We know in our country, 35 to 40% babies below 5 years are malnourished. Malnutrition and stunting is going, which is not going to develop good. Is going to be less. So newborn health, especially for preterm and small, we want to save approach. It is not only health to do it. We need invest from various other ministries. Poshan Abhiyan, Education Department, Ayushman Bharat and PMJ, private sector. So I would urge all of you obstetricians, kindly give your time to get and provide support to adopt few of the districts where we don't have specialists who can do cesareans. Support that, build the capacity. And I wish all of you with Indian Academy of Pediatrics, nurses, midwifery, so many, and we can achieve the goal of 2030 very quickly. At this point, 3 already are at single digit. We will reach that by next decade. Thank you, Dr. Vaishali, giving me the opportunity for talking. You are all your colleagues, and I wish we will work for the welfare of mothers and newborn babies. Thank you so much.
But sir, that was indeed.
Dr. Vaishali, please, 1 minute. Yeah, I agree with what Dr. Ashok has. And yes, we can antenatal steroid and is the practice everywhere, but in first hour is still only at 46 or 50% place. 46% mothers are doing breastfeeding in the first hour. We are weak in counseling. It's our role, of course, a role of all of us, but this important thing, breastfeeding, we are doing for the promotion of breastfeeding, for everything, but still this is the result in people are not providing breastfeeding. Thank you, Dr. Ashok.
Yes, sir. Yes, sir. Ashok, sir, for the wonderful guidance. Now, I would like to invite for today's inauguration ceremony Member of Parliament, Mrs. Supriya Tai Sure, the most dynamic young politician, a young lady who is national leader. She has to Lok Sabha 3 times and to Rajya Sabha once, and by a she's a science graduate university, and she's been doing tremendous social work from Yashwantrao Saman Pratishtha. She does this Pratishtha in literature, art, culture, and science. Tai has the best parliamentarian for awarded for attendance for 6 straight years. She is a young leader and she works for women's cause. I have met time in 2011 had organized Jagar Yatra against female feticide, where herself and supported by women walked the entire Satara to Pune, a distance generating awareness uh, in She is also a member of Peace Association where she gathered 30 young celebrities and media people and worked against, as we know, malnourishment. Women deliver. She also has been doing work against substance abuse, alcohol, smoking, and Tai. On a personal note, I have been your junior at in Mumbai, and we are happy that you have taken the baton and you will be working with us for this. It's an honor to please welcome.
Yeah.
Yes,
Very much for inviting me for this conference organized by. I first of all want to show my to every doctor in this country, every administrator, ASHA worker, for the amazing work everybody has done during the pandemic and COVID. Each one of you, and have only gratitude in my heart, for all you. Y'all are not just stars, but y'all are the real. And this very challenging times to never forget what other big issues in the last few months. We're so busy with the pandemic that there are people who really need attention or issues and illnesses which are probably larger and harmful than the pandemic are ignored by all of us. So you raise the bar, Vaishali, really, because you've brought a very, very emotional and a concern of every, especially a mother, because I think a woman can give to humanity is a child. And if your child is healthy, the mother is overjoyed. I mean, because I've worked for female feticide, that whenever the child is born, the first question we ask my baby, the minute the doctor tells your child is healthy, happiest moment for the woman. I've been through it twice, and I know it doesn't matter whether it's a boy. You want your child. That's all every mother aspires. And I do realize that when we women want a healthy child, but unfortunately, when you become a mother-in-law, then the gender. But anyway, I don't want to get into the gender. This is not the forum, but you're looking at an even more important and sensitive issue. And I think it's difficult and a challenging time, and it's beyond control. So every time you go to just, I think every mother is anxious to complete 9 months of the baby, because of course there's a science bit, in completing those. And if the child is premature, I know the doctors, the pediatricians, extra mile. I have very close friends, people I've worked with, children. I've had faced a lot of challenges initially to bring the child on. So it's a very, very challenging time. All illnesses, we don't have solutions. But I see that doctors can really, I mean, for me, they're not just, they can be gods. And I've seen doctors being gods. So when I start, people used to tell me, why is your, I said, that's for our safety. God is probably saying that go through that every nurse and the role of God this time. So go take their blessings and show gratitude. So every time when a premature baby, we don't have to wait for a looks at hope, only be it a gynecologist or and when a child becomes healthy, gratitude in our mind for those doctors who extra miles and hours, even so impatient and helplessly asking questions. And the doctors very patiently don't worry, all is going to be well. I don't even know if it's going to be well. But he assuring that the mother absolutely believe that doctor म्हणतात and that really helps. And as at the earliest, he's absolutely right that this is a very important thing, nutrition. Nothing, the pandemic has taught us. Then one thing is luxury. I mean, luxury items were watches, clothes, jewelry. Today, luxury is to get rid of this mask. Luxury that I am looking for right now in my life is damn mask. So it's really put our entire life into perspective. Child is born premature. The mother goes through, the family goes through, doctors are under pressure. So I think we all focus on nutrition. Every child deserves, and every mother, and you know, are brought up in a certain way. The tyag that you do, the better. The more hungry you stay, the greater. And I keep telling women, की फक्त उरलेलं तुम्ही खाल्लं म्हणजे होत नाही. The healthy mother, your entire family. So please love yourself. Holds the family. The mother can hold the family. If the mother is unwell, the whole collapses. So it's very important that programs need to be sick, and if the mother is healthy, 8 problems will be solved in our nation. Connected to good food habits, style, which is not very hard for us. Pandemic has taught us that there are many out, but nutrition is most important. The nutrition mission, I would like to put it. Dr. Dalwai is also part of this group. He had helped us immensely under Manmohan Singh ji. We had started regarding malnutrition, raised malnutrition issues. In every state, chief ministers, there was no party issues. It was not any. When it comes to nutrition, we are all side. It's like the pandemic. United against the pandemic. So against hunger and poverty, stand united against it. Solutions to eradicate it. You all have taken up this issue. Whatever I commit my parliament, and as a woman, as a mother, as a daughter, as an elected representative from our state of Maharashtra, dedicate whatever policies you all can at the end of this meeting can make. I'd be happy to take them forward. Assure you that together we can to bring a healthier, happier children in every home of it. You have to be born in a rich and poor and family. Child is smart. We are all gifted differently. We just need to identify together. If we put our minds to it, a difference to build a beautiful, which is not just about better lives for one of the leading countries, best heritage, best culture, diversity. I wish you all and your absolute best wishes and come whatever time and support you need in policy making. I will dedicate it to support you all. Thank you very much.
Thank you, Tai, for these wonderful words, and thank you for being Thank you from the 30 gynecologists from all across the country. Like Apli, Hakkachi, and we give it to you for being here with us today, being with us in this work against prematurity. And we would like you to wait with us of the newsletter. This is on and first of the many new awareness activity. It has some articles. So we would like all the dignitaries and Thai to release this letter.
No. I'm sure it's released, and congratulations to each one of you. So hard to make this news. To all of us, we will put it on our Facebook media platforms in whatever support it.
Yes. Be great help because it's an awareness letter.
Please send it to me in all the languages that you've drafted it in. I'll be happy to share it on all my.
Thank you. Thank you so much. Are we getting the newsletter?
Got it. I haven't got it.
Yes. This is the perinatology newsletter. Is preterm labor, and it's going to come in first part where we have covered the tocolytic agent. So, sir, request you to say.
Supriya ji for the kind. And thank you for to all our endeavors for this perinatology, for preterm, for low birth weight baby, extending your support, a big thing, huge thing for great motivation for all of us, for sparing your time and Dr. Weiss, very, very informative letter, and I'm happy to and we the newsletter on our website also. All our 38,000 gynecologists can be benefited. Please come with also, and I know you are going to bring more and more such newsletter. So congratulations, Dr. Vaisali.
Thank you, sir. Thank you very much, Thai, for being here with us. I would like to invite our invited guest, Dr. Thai. He's joined National Secretary, and he's an invited guest. Him to say a few words. And Dalwai is doing pioneer work in development. Till 2003, nothing much was known about development, and only sympathy was patients of autism. But since then, he has done revolutionary, and he has established centers in Mumbai, nationally and internationally. Patient for help. He has scientific individualized program and evaluation every for it. He is also has been working on child abuse as expert panel on community of protection of child. He is also my as a classmate and good friend. We are proud of our brilliant friend, Dr. Samir Dalwai.
Mr. Vaishali and respected Chief Guest, Mr. Member of Parliament, respected Sir Dr. Alpesh, please, Dr. Ashok, Sir, friends on the panel here. First of all, inviting IAP to participate with this wonderful, wonderful event. And I'm here on behalf of my national school by Parekh, who could not be here because of engagement. But Dr. Parekh himself is a PhD and he's a national president at the moment. And he sends best wishes to this endeavor along with Foxy and with NNF, because that we have to all work together for. Not just about the child who suffers, as we heard the member of parliament before, it's the entire family, the mother and the father, and the kind of mother has to hear in society are not new. It's not just the family, but it's also society at large, which has to bear a very, both socially as well as economically, the problems created by prematurity. So much so that, along with Dr. Mrs. Sule, on the Citizens Alliance Against Malnutrition, and one of the main interventions is suggested to the Honorable Prime Minister to ensure food security for 3 classes of people: children below 2 years, pregnant ladies, and adolescents. In the country, we know that even at a very young get married, and they will pregnancy, and that is one of the commonest causes of prematurity and low birth weight. It is a very, very effective intervention. So well by all of us to break these medications, but it's a social awareness towards the field of preventing malnutrition. One of the things I think Mrs. Sule spoke about so well. Besides this, look at the issues after delivery. Dr. Dev well and eloquently, there's nothing what he spoke as a neonatologist, but we must understand that these issues, and I like Ronald Illingworth said in his, the normal infant and the development, delivery or birth on the path of development, because actually starts at conception throughout early childhood up to adulthood. As occurs, it's a very important in the normal development of the child, because the child support, the child has oxidative, could be a host of other medical complications spoke about. And as a developmental, I am aware about the number of children, babies, but who come with not just problems, but there are studies with autism and definitely with and so many other academic psychological issues that as development to take care throughout the life of the childhood. And hence the Academy of Pediatrics would be twofold. One is that we need intense of the lady in labor once he's out of the NICU, because the early childhood is to look out for the child's development for her life. And to this end, partnerships that we need to very strongly. So Foxy, Academy of Pediatrics are 3 stakeholders like the government, the NGOs, and all the other help that we can get from legislators, and all of us working together along workers, along with the ASHA nurses, along with medical staff, that we can work on problems rising out of prematurity. So I'd like to say on behalf of Indian Academy of Pediatrics, Foxy, and to NNF, ye dosti, again we have to all work together towards this. Much on behalf of Indian Academy of Pediatrics, more to Foxy and NNF. Thank you.
Thank you, Samir. Talk, and like you said, yes, Foxy, NNF, and IIP working together. So, to invite.
Thank you, and please convey our regards. And tomorrow also we are again and a very big violence against women and girls. Starting our session with the selective violence in childhood. So again, IAP is there, and thank you. Collaborative work, Dr. Samir and Dr. Ashok, much, and if possible, spread this program in your association.
Thank you, sir.
This is a common program for all of your member can also attend this. This is a violence against women and I think all the doctors. Thank you.
So, Vaishali, work, not shall work. We will.
Yes, sir. Yes.
Yes.
Right.
Sir.
like to invite Dr. Kalyan Baramde to propose of thanks. Before that, ICOG chairperson, Dr. Mandakini Meg ma'am, is chairperson ICOG Foxy. She is vice president MWI. She is vice president AMW Council, national vice president 2012-13, and madam working in these COVID times, holding multiple certification courses, not only for the PGs, consultant, and all has taken education academics to the. Madam, please welcome to have you with us.
Good afternoon, everyone. Can you, especially, am I audible?
Yes, madam, you are. Yes, madam.
Okay. So, very good afternoon. And it's a great pleasure after, seeing Priya Sule talking on to our own respected Dr. Alpesh Gandhi, this, prematurity and other program to such a great level. Other dignitaries, Dr. Ashok, Samir Darwai, Dr. Varsha Baste, Dr. Pawan Dhir, Dr. Kalyan Barma, all the dignitaries, all of you. So everything, much has to be said. Only I want to say 2 points. Everybody has said that with the UNICEF program of IM in CI, UNICEF also. So there is a of the Foxy and the IAP and the central government or respective. Then they take up a training of basic worker, that is ANM worker, staff nurses, basic, and also the OBGYN. There are 4 or 5 categories of training. Especially with this kind of infrastructure where everybody has experience, must train these people. I think we should take it forward. What has been given by all the specialists, take it forward. So that is one suggestion. So the second suggestion is that, Chair, I would like to in the past also we have been ICOG certification course is important issue where normally take the training, and I think this subject with you and with your national coordinators also, and we are coming out with the perinatology 3-day certificate course of ICOG. That will be our concrete contribution of Foxy ICOG. Very important and sensitive cause of the prematurity. That is my commitment to this particular cause. Third thing very important is when for any program to be successful require a political will. So not only will you have got the Thai as a full motivated, fully knowledgeable person to support such important cause. Dr. Ashok, IAP, Foxy is already. I think we are going to have a very definitely, as Dr. Ashok, we are going to achieve from 57 IMR, we 8.3, and now for the SDG goal, definitely infant mortality is not. So with these words, especially everybody, and all the Foxy, I don't have any words for our because back-to-back super hit program, violence against women, Alpesh Bhai, and I'm always with. I think all the best, Vaishali, and whatever is required, please, ICOG from the ICOG point. With this, to all of you.
Thank you, Meg madam. Thank you for always being with us and for always giving points for so many. And this is indeed a welcome announcement by you that perinatology Fox program. Thank you, ma'am. So now, Dr. Kalyan Barmade to thank. He is the chairperson. My committee, his committee, together we formulated this 2 days program. Executive Council member of the IG Maharashtra Isa and convener of Save the Uterus Mission 2019 and 20. Welcome.
Thank you so much. I'm a vote of thanks. I thank Honorary MP Supriya, President and Dr. Ashok Devrari sir, Foxy President Dr. Sir, and Alvai from IAP. Really fortunate to have Dr. Chandravati Madam today with us, Deep Tank and Dr. Mandakini. I'm really thankful to the all honorary dignitaries for valuable time for this inauguration of International Parent Conference. I thank Dr. and Dr. Priyankur Roy. This conference a historical one, and I conclude by saying, "E dosti hum." Thank you all. Thank you so much. Vaishali.
Yeah. And with this, we are at the inauguration ceremony, and all the dignitaries for gracing and for their wishes and for their blessing.
Thank you. All the best. Thank you.
Thank you. And now I hand over the proceedings to Dr. Priyankur and Dr. Priyankur, we start with the first session of today's scientific Dr. Priyankur Roy is the National Coordinator of Perinatology Committee, FOXY, and he has worked enthusiastically and every day about how to go in these 2 days of conference. He is also done MS Fellowship in Infertility. He's consultant infertility at Siliguri. He is India representative for VETOC PICO at Rio in 2018. He's zone coordinator for perinatal and he's been gold medal for topping in MS University examination. He has published many papers and he has many credit. Diksha also here? Dr. Diksha Goswami our North Zone Perinatology Committee, FOXY, and Pushpanjali IVF Center. She received first runner-up award, the award in infertility, many awards, and many special interests are PCOS and reproductive endocrinology. I hand over the session to Dr. Diksha.
Thank you, ma'am.
Thank you, Dr. Vaishali. Thank you. And it was a positive inauguration, I must say, but it was a wonderful. We had stalwarts from, of course, from IAP as well as from, and it was a wonderful introductory session that we had. So perinatal is a very important session. I was telling my wife yesterday that we are having this, and she told me, she's a pediatrician, that pediatricians definitely prefer saying pediatric field, but we know nowadays maternity come up so well that gynecologists lot with fetal medicine, and there are a lot of fetal medicine specialists who are there in at present. So basically, with Lily, who formed the graph, and graph not very often nowadays, but we still, and we had the Indian Association of Perinatal Medicine, which was formed 1991, and we are proud Secretary General of it, giving the. So starting with the academic sessions, we have our legend ma'am who will be chairing the session. She's a professor emeritus at the KG Medical College in Lucknow, chairperson of the AICOG in Lucknow, enjoyed thoroughly last year. She was the president of the Lucknow Obs vice president of the Lucknow of 2001 to 2002, and number of publications in many national and written a number of chapters. I welcome you to the session, and I would like to kindly introduce our first speaker. I have Dr. Basant's slide, please.
Personally, I have known Basant first, and it's use him today for this session. He's MD, FRCOG, FICOG, his medical school, CMC Vellore. He's a Southeast Asia for safe abortion. He's the clinical examiner for in India. He's the member of ICOG 2050 to 20. He's honorary secretary Bengal of from 1890. Gynecologist awardee AO4 at Taipei. His welfare committee FOXY 13 to 15. The vice president elect for the year 21 to 22, going to be organizing secretary 2020, which means we with him in 2020. I hope we will be present and not virtually. So, Basant.
Thank you. Thank you very much.
Now stage is for you, and it's nice to have you here today.
Yes, ma'am. Thank you. Pranams Chandravati, greetings to Vaishali and the team. And pleasure to be here. I'll be taking recent updates on magnesium steroids for optimizing outcome labor. So I'll be sticking to trials and data which we have over the last. So that would be fairly recent on what we would like to know about magnesium steroid as far as preterm labor. So we start with magnesium sulfate. Whenever we talk about magnesium sulfate, we talk about preventing eclampsia from the MAGPIE trial. Eclampsia, which was very evident from the eclampsia trial in 1994. And then we have the preventing tocolytic when we were postgraduate, which was mentioned that magnesium tocolytic, which can be considered, came to know over the last 2 decades protection, and that is where most of the segment of the talk would be. So magnesium sulfate as the tocolytic before the Cochrane review, which was published in 2014, where they looked at magnesium sulfate in preventing preterm and threatened labor. So 37 trials, including 3,000 were analyzed who were given anti-magnesium sulfate compared to placebo, aim to delay the prevent preterm labor. And this was magnesium sulfate was effective at delaying or preventing, and no apparent advantages neonatal and maternal outcomes. So nowadays we do not magnesium sulfate as a tocolytic agent. We have other things, and we usually stick to other products and molecules, and possibly as far as now can be. But the important aspect of it, without doubt, is for neuroprotection is something which is in vogue 20 years, but still there are a lot of institutions do not magnesium sulfate for neuroprotection, even strong evidence to suggest that it is useful, advantages. It is less than 30 to 32 weeks, is less than 33 plus 6 weeks, 34 weeks you can use it, but better to definitely less than 30. Women with imminent preterm birth delivered in the next 24 hours. Modest effect, greater with earlier gestational age at delivery, means the earlier you, the more is the benefit. So the treat of pregnant birth to prevent one policy would be 46 minutes less than 30 weeks to 60 when it's less than 34 weeks.
you give it, the more is the benefit given for neuroprotection. It's about the dose. So coming for our GC, ACOG, almost all with a 4-gram IV 30 minutes, followed by a 1 for a maximum of 24 hours, occurs similar to the Zuspan eclampsia. There is insufficient for a repeat dose. So once you give it, it's done, and then you don't give it. There's a lot of proposed mechanism of how does magnesium really cause neuro. Nobody really knows, but there is. It blocks calcium processes, inhibits or delays cell ischemic events. It of pro-inflammatory cytokines and free radicals during the hypoperfusion, and also there's some suggest they increase the levels of neurotrophic factor, which is shown against neonatal hypoxic injury. So instead of controlled trials, we are looking at the analysis of the randomized controlled trial, where you are looking. So so we have got the details of the meta-analysis on the right side. Constantine et al. And Romero et al. So these are and all of them have shown a reduction in cerebral palsy in the prime reason why magnesium is used for in neuroprotection. So the 0.68 in the first meta-analysis, 0.7 in the 0.69 in the third one, and all well within before one. All of them are significant decrease in cerebral palsy effects. A little bit to magnesium sulfate in obstetrics. Is magnesium sulfate a safe initial magnet trial in 2000? Some fetal concerns that magnesium may cause some problems in the baby, but analysts have discarded those facts. Problem in the baby, but there may be some problem if we do not monitor it very carefully. So we know the respiratory assessment, and if there is a provision to check the levels, but more important, gluconate available in time. Coming to the second, which is steroids in preterm. Antenatal corticosteroids is team now. We all use it in most of our. Let's just discuss. Here's the Cochrane 2017. The antenatal corticosteroids for accelerating fetal lung maturity. Women at risk of preterm come very clearly, which we that this it supports the continual single course of antenatal to accelerate fetal lung maturity at risk of preterm birth. Single course of antenatal corticosteroids. Betamethasone, of course, you give 12 mg. If you're giving dexamethasone, you're giving 6 to 12 hours apart, in which we all use. A single considered routine for preterm delivery. Gestational age, you can give it till. We will discuss that in fairly soon. Few slides. It is important to note, however, that the evidence comes from high income to settings. Therefore, results may not be applicable to low resource rates of infection. So that is something important to understand. So though it is good, but at least at the same time, a little bit cautious. So exactly what does the antenatal corticosteroid review in 2017? They took of 7,700 plus women and infants, and as you see here, that this 0.7 RDS, intraventricular hemorrhage, enterocolitis, all positive with antenatal corticosteroids. Concerns which a lot of us have regarding, and it does not increase choriambic or endometritis. So whenever you, even though 2 doses, a lot of people are apprehending increase the potential of infection. Should we give steroids? Use which is recommended between 24 and 34 weeks generally. Now that is something for high risk of within the next 7 days. So that's a strong evidence. But what about before 24? Before. So before 24 depends on your period of viability. We are working in a setup. Babies of 22 weeks can be managed. There will be a multidisciplinary consult before antenatal corticosteroid in that case. And after 30, there's a different coming from different bodies considered in women at risk of preterm birth days between 34 to 36. A little more liberal. RCOG, some SOGC, again, not very clear. And we do understand, similar to the MAGSA, you give it, the benefits would be the earlier you give it. So generally no routine administration. A lot of people would like to give it routinely before, and there's not much of evidence to suggest a useful thing to do. So benefits discussed: antenatal corticosteroids, perinatal deaths, RDS and IVF between 24 to 30 preterm birth risk. Respiratory at 34 to 30 respiratory morbidity, and it should 7 days before the delivery. The other things which antenatal corticosteroids, which we do not hear, does increase maternal blood glucose level. This is something which would be persisting after the first dose. So if she's a diabetic, of course, she needs to be possibly at the insulin needs to increased risk of neonatal hypertension has been noted in some trials. Movement in the first 24 to 40 is a research-based finding. People of us do, we find that after movement is less, that is research-based, but they have seen that yes, it does. Then there's a decreased birth weights and head in use of multiple. Then the question, which one? Beta dexamethasone. In indirect comparisons, we see betamethasone reductions in chorioamnitis, RDS, and disease compared to dexamethasone. In dexamethasone is associated with a greater reduction in ventricular hemorrhage, lower length of NICU compared to betamethasone. So effects on the outcome is similar. Coming to repeated, limited evidence on the long-term effect of repeated corticosteroid therapy. So a lot of this lapsed for 7 years to give a single rescue dose. It is a subject, and there is insufficient evidence for the use. And evidence from a large higher risk of neurosensitive disability and a composite of death and disability, taking these factors were more when multiple courses were given. Special populations of multiple pregnancy, you do not increase the dose. Medications, diabetic women, again, injections, but again, you have glucose monitoring. Obese or BMI is high, it does not affect. If she's got a fetal growth restriction, you have the same dosage, you don't change. But this is a new thought which has come up recently. I'm to share with you before we wind up the talk. The ACT cluster randomized trial conducted in 102 clusters across 6 countries. It compared an birth attendance at all levels to identify women at risk of administer corticosteroids and refer women at risk. And a pre-specified secondary outcome was stillbirth. So this is something which the idea of training birth at 25 women at risk of preterm steroids and refer women. Find from this trial, they found that increased risk in stillbirth. Because here you're trying to identify, you're trying to give some, and you're trying to refer. But here, an increase in the risk of stillbirth, and that was people are really now just the reasons why the Cochrane recommends that in a poor setting, we do not know the impact of antenatal corticosteroids or places rate, how much of the benefit is to explore or more studies need. So a higher rate of stillbirth in the intervention to the trial may be a reason. Differences an increase in maternal infection. Coming to the last slide, the takeaway message section of the symposium, the benefit of magnesium sulfate in fetal. Everybody should be aware of this. Women in risk of preterm labor in the next 20 must be offered magnesium sulfate. It is old, it is time tested, and it is, of course, you should have the monitoring which you need sulfate IV administration, but not be denied this. Antenatal RDS, IVH, parental death, those benefits are long lasting, and 24 to 34 weeks, there is absolutely later giving it later, repeat doses, question mark. Guidelines and standard protocols in many health denying women the benefits, and these are must tools which can be implemented perinatal mortality and morbidity, and would be immense. So emerging research on the ANCS needs to guide clinicians on evidence-based use. I thank again Made, Dr. Vaishali, Priyanku for a wonderful perinatal. All the best. Thank you very much.
Sir, I think it was a very, very clear talk, and you've given a very. I'm one of the using this Maxself and I think what you said, that was very right, that the clear there about the many people are not still using it. Maybe that we need to have a clear on this also, as we have a and I think many more people. It was a wonderful talk. I'm sure each one has talk, a very clear message. Thank you.
Thank you, ma'am.
Okay, I request everyone to adhere to the timelines, as we also have international talks. Thank you.
Thank you, Priyanka, for having me, Vaishali. Thank you very much. Thank you.
Thank you, Dr. Chandravati ma'am, for such a wonderful session that ma'am has chaired, and Basudha. Thank you so much. Now I have co-moderator Dr. Diksha Ghosh.
Thank you, Dr. Priyankur. A very good afternoon to one and all. And I would really like to thank Team Foxy, our President, Sir, Vice President Dr. Archana Base, Ma'am, Dr. Vaishali, Dr. Kalyan, to making me vision for this magna Foxy International Perinatal and giving me this responsibility for coordinating the event today. But I am really excited of the program, as coming up is a debate session on a topic which has mandate till today. Cervical encirclage, a prevention. On one side of the star of PAC from the Kalyan Barmade, and we have a really skilled with razor sharp rebuttals, Dr. Charmila. So without further ado, I am chairpersons for the event, and I to welcome Dr. Charmila, sir. Sir is the past president of Pune Obs from 2011 to 12 and 2016 to 17. He is the founder president of ISOPAP Pune, editorial board of perinatology, and a very serious member of Foxy Perinatology. Sir,
Thank
our
you,
next chair. Welcome, sir. Our next chair, Sheila Mane, ma'am. Ma'am is a very Foxian. She has vice president of Foxy. She has secretary of the much loved AICOG 2019 in Bangalore. Chairperson of the Safe Motherhood 8-11 and Foxy Emergency Obstetric Care Training Programs. I welcome you, Sheila ma'am. Now request Joshi sir to introduce our first speaker, Dr. Kalyan Barmade.
Thank you. It's my pleasure to introduce Dr. Kalyan Barmade of Public Awareness Committee, FOXI. He is the Executive Council member of IIG AMOX. He has been the convener mission FOXI 2019, and he is the president of committee. Friends, first of all, to thank Vaishali for inviting me here. Start of the inauguration and scientific program. Debates find them most interesting part of any. And talking about the labor, we are preterm birth, the consequences of its but then the baby for survival, and we NICUs to receive those babies done to prevent that. As they say, a stitch in time will save 9, or prevention is always better. The same. So to speak for the I have Dr. Kalyan Barmade from Latur here. Kalyan,
thank you so much. Introduction. There is no debate for the cervical cerclage as preventive intervention. You are doing the clinical practice apart from practical knowledge what you are now. This of surgery, we say that cervical prophylactic intervention that has been used in second trimester loss, yet it remains one of the surgical intervention. The cervical insufficiency is difficult to make and is usually effective based diagnosis current second trimester loss following painless cervical dilatation, absence of contraction, bleeding, or other. The exact etiology of preterm birth is not known, multifactorial. Factor gestation, placental insufficiency cause preterm birth. There are drugs like tocolytic agents. Research has focused on prediction, primary prevention, which is important. Whether the cause of onset of common pathway is leading to preterm birth, shortening, and dilatation. Hence, cervical cerclage is a primary prevention technique which I propose. The role of cervical mechanical strength and act as ascending infection. Cases of cervical dysfunction primary, but true cervical is probably rare. There is no diagnostic test for insufficiency, and the diagnosis is retrospective depending on the part. When to do a cerclage, diagnosis of true cervical insufficiency is difficult. Labor is most probably those women with the highest risk of preterm delivery to have highest probability of getting the benefit with the relatively few. It would seem prudent to offer cervical to them. The evidence is whether cerclage is beneficial. One cervical shortening is what cervical length it is to be done. In a singleton pregnancy, from past obstetric history, cerclage to the patient, which may reduce the preterm birth, but further large studies may be required. Cervical should be a marker of generalized interaction and a strong of spontaneous birth. What is available? Progesterone therapy, cervical cerclage, because it can be placed by anybody who is MBBS or DGO practice. It can be done by a transvaginal, transabdominal, or a laparoscopic. History indicated cerclage, and nowadays we are doing ultrasound cerclage with therapeutic measure in length shortening seen on performed at between 4 weeks of gestation. What is going to do about this cerclage, know about the cervical status, rescue cerclage, which is a image measure in case of premature dilatation and exposed feet, where the patient is having sense. So these are the things where cervical helpful. As everybody knows, anybody who is trained in MBBS gynecology can do McDonald's. It is just putting a suture, that is bursting suture. Though Shirodkar is slightly difficult, MD and done 6 posts in gynecology, simply do the cervical cerclage. I know there are who have 5-6 abortion, 3 cerclages, still they have abortion, and these are the patients who require a transabdominal cerclage. This can be done very effectively in pregnant status also, and status where you are supposed to tie at the level of which is anatomical internal loss. Advent of laparoscopy, we can do cerclage in non-pregnant status because say it is very difficult to do abdominal cerclage. I need that training, but if it is done in a period like this in a non-pregnant, this procedure is going to take only and can be done effectively, and this patient are going to deliver. So what is the management of cervical insufficiency? Those patients first or early second trimester is vaginal cerclage, if previous vaginal cerclage, 1 or 2 second or preterm deliveries, expect do cervical length, and if length is below 2.5 centimeter, a prophylactic cervical cerclage is going to help. Cervix which is more than 1, if there is no chorioamnionitis, which are going to be helpful cerclage. So surveillance, all high risk group, we can do a cerclage and save. There is a dilemma about multiple. It is said that it is not recommended to, but in your clinical practice, you are done IVF pregnancies. What do you do in your clinical practice? Yes, important in a cases of uterine anomalies, surgical cone biopsies, clinical practice, cervical cerclage, and those radical tractectomies, concomitant cerclage at radical tractectomy should be in the COG. But what do you do in your clinical practice is cervical cerclage. And this transabdominal cerclage can be done rescue cerclage, and all studies have shown that a cerclage which is done electively delay the risk of infection, and you can help this patient by. There is a problem of preterm care. India is a country where there are so many babies prematurely. 3/4 of these dead with current cost-effective with progesterone and cervical cerclage. As you know, India top labor. How we are going to help these poor by giving costly medications, or only cervical cerclage intervention, and all evidence effective cerclage may be indicated when there is a congenital or acquired weakness in the cervix, cervical weakness. It has been suggested that may be helpful if the cervix is short. In the subgroup whose history suggests cervical incompetence, cerclage may not be helpful for those patients short cervix without history of incompetence. Other studies which shows that influence of cervical interventions upon the incidence of neonatal found that the deliveries of patients. And nowadays, this new article which says that cerclage is revisited because of surveillance of the cervix and of emergent cervical cerclage in women who have deemed high risk for cervical incompetence. Secondly, pre-pregnancy procedures to deal with cervical intraepithelial neoplasia. We are going to do all this cone biopsy in this patient, so intervention is required. And lastly, refinement of laparoscopic approach with the potential maternal morbidity and outcome. We are going to do laparoscopy also. My time is all. So the recommendation by SO that in women with history of agency, urine analysis, culture is to be. Yes?
Time is up.
So I'm going to conclude by saying in women with classical insufficiency, prior vaginal successful, but abdominal cerclage is going to be helpful. Thank you so much.
Thank you, sir. And you have all of us and convinced us that is the way to go. And I invite Dr. Sheila Mane ma'am, next speaker, Dr. Charmila Arabu, who will be speaking again. Sheila ma'am.
Yeah. Thank you, Diksha. This opportunity to invite Dr. Ayabu. I think we will have to really bring charm now. That's cervical encerclage. Okay. I think Charmila is again a good academician, and most of us we know her. She was a chairperson of Clinical Research Committee, and she also the Best Committee Award for her of the Merudara Hansotia. She awards to her. She has she had also Yuva Foxy 13 at Trichy, and she has won 5 secretary of Trichy OG. And also she has received Mr. and Mrs. Women Empowerment of Foxy. She is currently a ICOG Governing Council member of a handbook on RPL and on high-risk pregnancy. And also involved in the FIGO project on abortions and Foxy and ovarian reserve. So over to you, Dr. Shamila, on cervical.
Thing is will not work. One second. Yeah. Screen. I'm grateful to Dr. Vaishali and my Barmade for the opportunity. Great to have a great conservative at heart, Dr. Sheila Mane, because Dr. Kal so many self goals that I got all my self. He said that the only to prevent a preterm birth is cervical encerclage. I don't think any obstetrician worth the salt will. So many other options to manage preterm birth compared to only a. And that too, such a talk coming to save the uterus mission is astonishing, because when you want to save the uterus, why don't you want to save also, which is going to cause harm? Other options to manage preterm birth. Primary prevention technologies, there are secondary, there are tertiary prevention methods to birth, and the secondary prevention method is the one cervical encerclage. But please remember there are other options, a secondary prevention strategy, preterm birth, and only one cervical encerclage is left almost to thinking that only cervical encerclage a preterm birth. Is cervical secondary preventive modality in preterm birth? Even no, it's only one among many. One. It is only a part of the strategy. It is not the only strategy. Low on the order of management strategy a preterm birth. Evidence is not for cervical encerclage all patients. It's only in a selective. This systematic review by N to that point. He took 15 guidelines and he tried to come to a consensus regarding the use of cervical, the prevention of preterm birth. And the questions which were asked in the study were elective cervical encerclage in a lady, 3 previous preterm births? Yes. Should we use it when she has got only 1 preterm weeks? A resounding no. Should we got a short cervix and has got no preterm birth? No, you're not supposed to. Cervical encerclage with a cervical length 5 mm and there's a previous it, but he also gave in his talk like progesterones and pessaries to indication. So there is only one out of this. Regarding the other 4 questions, will you use it one high risk factor like a uterine anomaly or cervical surgery with no other indication? No. Clutch. Will you use it in twin pregnancy? Not supposed to use. You can use it, as he kept on reiterating that point, like successful vaginal cervical circlage. You have a lady who has already failed vaginal, but that's not the only. You can keep on using cervical encirclage as a preventive modality for preterm birth. Will you use a rescue or emergency? Please, Kalyan, all the guidelines say not use for threatened preterm labor before 34 weeks as a rescue method, because work in all your patients. So out of 7, there are only 2. You cannot use it even for where probably an indication of cervical encirclage fails the test. So there's indication where you can use a circular or you can use a pessary. All will have similar effectiveness. Symptomatic singleton pregnant women, preterm birth, and she's showing a short cervix in this current pregnancy. Still, you can still prefer vaginal progesterone and pessary. Her choice comes to does not come into it. And what is about the secondary prevention of preterm birth is only and only indicated in pregnancy, but the previous preterm birth with the cervical shortening in the current pregnancy. That is the main indication. Long-term outcomes are definitely not improved, and the maternal increase when you put a stitch in her. A clutch should never be indicated in a twin. She has got a short cervix. You may do it in your what the guideline says, and we know the when you put it in twin pregnancy, and if she goes to the place, what are you going to do about the stitch? Cerclage will remain an indication only individually the patient, and only when. And Kalyan, please don't say that there are no complications of cervical cerclage. That Harry, anybody who's finished an MBBS, it can cause an intraoperative bladder cervical trauma. It can cause a rupture of the membrane, cause bleeding, and do not Shirodka cerclage. When you put it in removal, and that will carry an aggressive procedure to the pregnant patient. Laceration or trauma, if she goes with the suture in place, cerclage, short cervix will be actually a pregnancy loss. Whatever pregnancy you're trying to save will be procedure, and trans-abdominal cerclage will require delivery by cesarean. Other methods before you go into such. Is there any justification for cerclage can actually cure? I don't think so, because spontaneous syndrome, it's just not cervical. It's made of several anatomic and related elements, which may include the uterus and contractile function when she goes into pre. It may be decidual activation and the lymphatic integrity where there'll be a preterm. The only indication where she can have a and you said it can be done only retrospectively. A primary suture for every lady preterm birth is going to mission of being in saving the uterus mission. Moving on to IAG, I know that because laparoscopy is the one you talk about. Preterm birth results will come when there's an interaction of multiple stimuli and pathways. Recognized clinical syndrome of preterm. Not an oversimplification of the cervical factor where you put a cervical suture. Problem which is going on. There's a larger and more complex spontaneous preterm birth. The antecedent of cervical insufficiency is fungal anatomic deficiency. Cervical longer continuum, which is influenced by endogenous and exogenous factors. Insufficiency may actually represent an anachronistic, incomplete work of the pathophysiologic process, which is pre. This treatment is without validation. It should always be questioned. Treatment understanding the complexities of the spontaneous preterm. Please select your patients and tailor according to the patient. Even your effective so-called therapies will appear ineffective when you're unselected or a poorly selected patient. And why do surgeons still continue unnecessary surgery? That's a question I studied in 2000.
Sorry to interrupt, doctor.
Yeah, I'm finishing. The 21st century terms of the observed reality, that's board a commercial airplane or a nuclear submarine than to be if we are going to do surgeries for every patient. We need to embrace patient safety as a core and eliminate the phantom menace of unnecessary surgery and the associated patient harm. The responsibility is definitely not negotiable on us. Thank you so much. Thank the organizers for this so much.
It was really interesting to talk on personal issues. Women with a history, second trimester, I got 1 minute. Women with history of three losses or extreme premature deliveries in cause other than potential insufficiencies identified patient who should be for cervical cerclage weeks and those with physical history of cervical past has to be given benefit of doubt and has to be offered. That is what I said. I put a stitch for all patients. It is for the patient who history of preterm labor and whose history indicated an ultrasound is the only indication for cerclage and not for all the patients. Thank you so much.
I think you said, sir, that you wanted only for a select, not all the patients.
It is not for all.
Yeah. That cervical encerclage is it a prevention for all preterm births? It's
Sorry
never
to interrupt.
it's
I
preterm births.
request everyone to adhere to the time.
You didn't give me 1 minute.
We
Nirav,
have 1 minute
Nirav,
to
you gave
discuss,
me
1 minute to discuss.
No, we did not keep any rebuttal.
Oh, I got email.
Okay.
Kalyan only agreed that it is patient, so debate is over.
That's fine.
Thank
It is
you
not
both
for all.
our speakers.
Diksham, may I say a line?
Yes, sir. Yes, sir. Please. I was.
Sharmila, you have put up yours very forcefully. Probably you have ended on an amicable note. Certain points you have agreed where the cerclage is absolutely indicated. On others you have disagreed. Have been very gentlemanly. I was hoping that and draw blood from each other, but it has been a well experience. Thank you so much.
He gave me.
He's my teacher. I can't.
And he gave. Cannot draw blood from him.
We are virtual. What do you say, Sheila? Away from each other on the
Your
virtual mode.
discussion helped us choose the patient properly now. Do the cervical encerclage and manage conservatively. Nicely put the primary, secondary, and tertiary. And again, you know, the anatomy and Dr. Kalyan came out not always anatomical. Sometimes because you know the cervix, even if we have not, sometimes we know suddenly it opens up. Charu Chandra Joshi will agree with me that there are always aesthetics, when we not put it will come, when we have put the G may not. Surprises, I think both of them did. Okay, congratulations.
Very well.
Much
Aesthetics is
to
all
both
about
the
surprises. Actually summarize the whole thing.
Yeah. Both the speakers and our respect. And as it is evident that we're not over and we all agree on a case-to-case basis that we make our moving on, I invite great pleasure the chairpersons for our strategy section and Ravinder Singh Pardesi sir has been the vice president of Foxy 20 is the vice president has been the is the vice president among 2020-22 at several conferences, chair committee, and has presented many national conferences. Welcome, sir. Next chairperson is Dr. Lakshmi She, is medical director Shrikant Fertility. She is chairperson designate 20 national corresponding editor Jobs and Gynae India Jogi, national secretary AMWI Foxy 2012, founder president of ISOPAB Vidarbh chapter, and recipient awards, delivered many orations to her credit. Welcome, Lakshmi. Our next is who has been one focus during this has been on the health of our premature babies, and talking on this very important issue of periviral micropremie outcomes is our next speaker, Suryavanshi sir. I invite Dr. Rajiv Pradesi sir to introduce Dr. Pradeep.
Hello, good afternoon. Now, I would like to invite Dr. for the next talk. He is Professor Department of Neonatology, Pune, Head Neonatology and Hospital, Pune, Chief Neonatologist, Noble Hospital, Pune, Department of Pediatrics, Bijapur. Then he has 32 articles, published important 3 national guidelines, 12 books, and in author neonatological ultrasound and neonatal ecology, newer insights in perinatal point of care neonatal cranial ultrasound, neonatal lung ultrasound, and in mentorships in India. So, over to Dr. Pradeep Suryavanshi, sir.
Thank you, sir, for a kind introduction. I will just share my screen. Thank you, Foxy and Dr. for allowing me this which is peri-viable births and PREMI, or we call ELBW. Now let's go before. We all were afraid about the outcomes of less than 28 weeker and the babies who are less than 1. So what is the current situation where we are standing going ahead in the current scenario? We will be discussing a little bit about prematurity, which is already discussed in the previous class, and the outcomes about these prematurity. So currently our NMR is high. It is around from 4 to 5. Lot to catch up. No need to say that most of these occurring in the first 48 hours of, and the commonest cause now the tier 3 cities is the prematurity. Global burden, the India accounts for 30% of the preterm birth. 1/3 of the death is because of the prematurity. So when we talk about this prematurity, troubling or problematic, 32 to 37 weeks. But I'm considering that we are doing good. I'll be discussing less what is current scenario, peri-viable births. That means 20 and 24 weeks, where the Indian moment. So for this one, so let's see about the current morbidity and the final. I purposefully put this term as morbidity because in India, this is very, very important aspect, the preterm and the. So just go back to the Western data first about the. So the currently most of the Western people, they do 22, 23 and 20. What they are showing their data, if you see the survival of 20, 24, 25 weeker, from 22 around 20%, 24 40 to 50%, and 20 to 80%. That means the survival by day. While in India, if you consider at present moment, cater 22, 23, and 24 weeker at most of the centers. Some centers will come to that discussion. So remember, in the Western culture, 20, 30, and 40% of survival. But if you see the number of the to severe disability in these babies, 24 weeker is around 60 to 80%. It is about 50 to 60%. Weaker is 30 to 40%. Weaker is 20 to 30%. So they are doing good job for 24 and 25. That's why their guideline says that everything, they do everything for 20 years, and they do consider 2 and 23 weaker, depending upon there the parents take the decision for 22 and 23 weaker. While there is no option for 24 and 25 weaker, they do. If you see the Canadian society also data is 2 weaker 20%, 23 weaker is around 24 weaker is 60%, onwards is a 80% survival. Yes, the things are changing. If you see the Canadian society, the moderate disability is for 50%. So 22 weaker we are considering 50% mortality, while 25 weaker we are considering 20%. That's not a bad number when IVF preterm babies. And that's why their level of care starts from 24 weeks onward. The developed world, they have okay for 22 and 23 choice to the family. For 24 and 25 week no choice, their perspective. Similarly, the European countries, which is and the numbers are same as 60-80%, and those numbers. But what about Indian Medical Association, IAP and NNF? Because of the issues, consider a 28-week viability. We still consider kg. We all know the famous 40. That is where we still have this issue. Lot of tertiary care in the most of the cities, they are already onwards. And hence, about India, we do see a lot of these newspapers. This is what we smallest baby, one of our students has. So if a city like Udaipur 100 gram, that means proper putting into the perspective of these babies. What we NNF to have a guidelines when we consider those units who are be accredited by National Neurology Forum, they should cater acres and above 500 gram. Where they have unit 3 accreditation above 750 grams and above 20. That's a reasonable from Indian perspective. What about the data about the last 10 years about the Indian perspective? This is our own local data or our own local Pune city data to you in the form of mortality in these babies. Australian data about the hospital is peri-viable and micropremi babies. Naturally, they 4 to 5 months in the hospital. I have taken gestation-wise data about 25-26 weekers. Finally, when there is a 24, counsel the family, be careful. Long-term morbidity in 24 weekers. Myself and my units where I'm managing in Pune city as a Bharati Hospital, global hospital. Most of the places we do tell them that okay, we are in the slight zone, but 24 week onward we are on there, and we do say these are the numbers about their duration of hospital. What about the survival? This is I told you the data about the Australian data. I onward to 80% when. So if I consider city data, most of the babies we are in safe zone now. 1 kg, if you see between kg, we are talking about 70. That's a good number in last 5 years. Between 600 to 750, we are talking about 60% data, and below 600, we are talking about 50% data. In that, it is not all negative. Technology is improving. The accreditation system has helped. Outcomes of ELBW has improved drastically in the last 5 to 10 years. Support need. They do need a PPAP. Definitely, requirement of the support is more. So the babies below, almost 90 to 100% babies, invasive or non-invasive support, less than 750, they do require support, and that's where you require team to monitor these babies. What about the need of definitely the duration helps. Duration, family wants to know all these numbers. Important from the obstetric point of view. We're talking about degestation, then long-term mobility from their social. The babies, when we're talking about the respiratory support, 750 grams, then 30 to 50 days of conventional. When we are talking about less than 7, talking about 30 to 60 support. So it's a very important because these are the babies who require more. What about the long-term lung problems, what we call BPD? Around of the BPD in these babies are from 30 to 50% rates of the BPDs are there. So we need rates when we are talking about the long-term morbidity, brain bleeding, because that's the main important aspect of life about these ELBW babies. So if I say babies between 700 to 15 to 20%. So previously those numbers was 40 to 50%. That number has come down and has improved drastically. Less than, we still have 30 to 40% of the issues. What about the NAC? Are between 5 to 10%. Hence, they are also manageable. Rates in these babies, 5 to 10%, and those babies definitely 15 to 20% of these babies does happen. What about moderate and severe disability? When we consider about India, that's where we require not only follow-up clinics, we require, and good thing has happened in the last 10 years. Improved follow-up setups are increasing day by day, and if you see the long-term moderate, the data of the last 5 years, 526 speakers, they have 30% of the long-term moderate to severe, while 26 to 27 weeks is only 10 to 20%. About 28 weeker, it's around 10. That's a not bad number when we these terms, but definitely that's how the data. These are the admission from Bharti Hospital around 2000, and we can say that death rates are around 2%. That day by day the teams are improving and the outcomes are improving. If you see the ventilation per year and the survival on the ventilation is around 10%. So ventilation survival is improving, but definitely there is mobility when we comes about our micropremies or ELBW babies. This is where we down with the family because a lot of insurance they don't cover. So almost to 70% of the babies when they come, they are without insurance. And we are talking about the financial, the rough cost. I'm just talking this rough. Every hospital plus minus addition happens. The baby when we are talking about less than 1 kg, most of the hospitals between 2 to 5 lakhs, and those babies who are less than 750 lakhs. That angle also is definitely the teaching hospitals are doing when it comes to the Pune city. A lot of teaching institute, and that's so with this, the obstetric point of view, 28 weeker always at a higher center because as you know, of the inborn deliveries is much than the outborn deliveries. 34 weekers, if we could able to do facilities of good NICU is available, better. In-house delivery 100% better than outborn because the golden hour which we catch up in the in-house comes in a better way. The EL they are getting, that is micropremia outcomes are getting. Our obstetric colleagues are happy with our results. Naturally, they are also feeling the happy families are going home, better outcomes. I believe good NIC backup at a tertiary, what we call tertiary centers, that is or level 3B unit, we should cater the baby 100 gram more than 25 weeks. Definitely with a good backup follow-up. These would be the one which is our target. And I think with this target group, if we see that,
2 minutes left. Thank you.
yes. Thanks for information. So when we are talking about, we are not only talking about the short-term outcomes. We are talking about the long-term mobility. So just to summarize, when we consider 26 weeker in India, those babies between 600 to 800, we are talking about the survival rate 60 to 80%. When we are long-term morbidity, that is moderate to disability, which is in the form of neurodevelopmental outcome, we are again talking about the 6% good long-term morbidity, 26 weeker. When we talk about between 27 to 28, the survival 80 to 90%. That is in the last decade. Those babies 9. Duration is yes is there, but outcomes are. And I must say that there is no issue about more than 28 weeker. I think I would like to stop here because the future of India is preterms, ELBW babies. If we give a good NICU care with him, I think we can able to manage with the good outcomes. Thank you.
Thank you so much, Dr. Pradeep.
Thank you,
Doctor.
Thank
I
you,
mean,
Dr.
you have given comprehensive overview of these extreme premature babies, and your these babies was really palpable. You have given a very clear take-home message for all the obstetricians council, these parents whom we are expecting mature like 22, 23, 20. And I would like to add one thing, that it is a standard to involve your neonatologist prenatal period itself. Years for each and every pregnancy, it is my standard to involve a neonatologist. Who is the neonatologist? Who is my team? I am comfortable. I send those parents for counseling so that they are in the parents and the neonatologist, because you only said 2 weeker, 23 weeker, 24 weeker, the long-term morbidity, and sometimes at the decision of the parents is financial both, because I am in our parents, they just click want baby to survive at all. It is you neonatologist who will be counseling them about equally about the long-term. So only survival does not matter. Age-old dictum that everyone wants a healthy child, to be very frank. Yes. I mean, you, me, everybody wants a. It's a long-term life ability for the parents. Extremely premature baby with a long-term morbidity. Pros and cons, the balance, decision of the couple, and here neonatologists really don't have any say. We can only counsel. The things have changed. Previously, I had them 28 weeks, 1 kg. I also tell them at 24 weeks, please understand and use decision. So it is a mutual decision between parents and neonatologists. But yes, it's a for all the parents concerned, obstetrician also. I mean, we see our babies grow, survive, and to be healthy. And we really wish more and more neonatologists like you, passionate about these extreme premature, who are concerned with their welfare, them to live that too with morbidity or no morbidity, and your passion and your talk was informative, and it was full of hope. All the stakeholders. So let's
much.
the better days of the premature babies in India. Well, it's really bright in India. All the very best, and thank you so much for your fantastic talk.
Thank you, Lakshmi ma'am, and for this wonderful talk, and especially on for partnership between pediatrician and moving on. As all are searching for that elusive help all our pregnant women. He's speaking on the evidence regarding progesterone as is our ever charming, ever supportive, and dynamic Secretary Dr. Jaideep Tang sir. And really want to invite Dr. to introduce
It's always a to introduce a very humble, hardworking, dedicated Foxian witness to his sincere since last 25 years, camera shy person, and always each and every Foxian from west, north, south, each and every corner of India, you phone him, Secretary General, he is always there to help you come particular crisis. To follow Dr. Jaideep, as I already very dedicated Secretary General of, we are very fortunate to have managed our Foxy affairs. His immediate past Mumbai Society, his chair Vigo for the Committee of Safe. He is Deputy Secretary General of, and he has been awarded with many awards. He is a thorough academician. He has many publications to his credit. But friends, when it comes to representing Fox to the Supreme Court or challenging certain always at the forefront. Him reading the 1,000 pages material before the Foxy petition to represent Supreme Court, he has succeeded. The Foxy cases for hysterectomy cases, for cesarean section, personally visited Delhi, represented Foxy at the Supreme Court. We are very, very lucky. Dr. Jaideep Tang, managing Foxy affairs. The floor is yours for your this international perinatology.
Thank you for that very kind and generous introduction. You were introducing me. I would have made sure my listen to that nice introduction of mine. I must first begin by. I must thank the other chairpersons, Pardesi Sheila Mane, for chairing. I must at the beginning apologize. Sorry, I was supposed to speak at 3:20. I had another commitment at 4 o'clock, so I speak there, and now I have come back. To Vaishali, Priyankur, who have put this wonderful event, and also to all the speakers who are going to compensate, I will try as short as possible. To speak on progesterone, and we are going to try and look at what this whole concept of have started with this efforts of Professor Paul Ehrlich. This picture, you're holding a document, possibly which was known as the magic bullet. And it's not a new endeavor in medicine to look for silver bullets or to look for magic pills, which would take care of extremely complex problems in a very simple and concentrated way. And one of the things that we have been looking to solve this extremely preterm labor and delivery. But the first question, which progesterone? After all, there are so many progesterone which are available. And very categorically say, if you are going to use natural micronized, do not use it orally. Oral natural micronized progesterone probably absolutely no effect. If you want to use a oral progesterone, progesterone, We'll be looking into the evidence of the efficacy of preterm labor later, but this is just the point that if you are looking for, don't use natural micronized progesterone, use dydrogesterone. You could use progesterone, but intramuscular oil-based injections, and these oil-based injections are comfortable to the patient. And when you're talking about preterm labor, you're talking about a extent for weeks and months. And to expect patients to take these IM injections every day, it's unfair if I make a patient because these are painful. That is used to deliver it because it's oil-based, is long and thick, and it causes sterile abscesses. There is in OHP, which is given, and that is different from this IM progesterone that I'm talking about. This IM progesterone about are the daily progesterone. Progesterone is now available in access, but suffice it to say there really is to look at these kind of preterm labor. And so we come to what has got the maximum amount of progesterone and preterm labor goes progesterone. The reason why progesterone is preferred is probably because vaginal progesterone has a first pass mechanism through the uterus, and therefore availability of progesterone at which is the uterus is probably the maximum. This is quite similar to hepatic metabolism which exists for certain drugs taken orally. First pass through the uterus makes for rapid absorption, a relatively high bioavailability, a possible reservoir effect, and most of all of local and systemic. So these are all the various forms in progesterone is available. There are micronized vaginal gel, and effervescent tablets. There is good evidence to show that it doesn't matter what form you use, but most of the evidence which surrounds vaginal progesterone is tablets and the vaginal gel, the form. It's interesting to note where the serum levels of IM vaginal progesterone. IM progesterone has much higher and better, supposedly better serum levels. When you look at the action, not much difference. So if you're looking at efficacy, comes vaginal progesterone will do progesterone, despite the fact with IM progesterone are much higher. Progesterone act for preterm is supposed to be utero-relaxing. Metabolites of oral progesterone, anxiolytic, hypnotic, and we are not, as I said, looking at micronized progesterone given as a first line of. There were concerns about whether cause any kind of enamel to the fetus, and again there is so that progesterone did not affect embryo fetal viability formation as far as the fetus is concerned. But this is one of the earliest studies it all, which was prevention of recovery by 17 alpha hydroxycaproate, where weekly injections and 50 milligrams of 17p to a placebo, and these were fetal delivery or up to 36 that infants of women who were treated had significantly lower rates of NEC, IVC, and the need for oxygen. So 17 became quite method. Vaginal progesterone has got all these several studies, which so taking a bit of a deep dive, more important studies, if you for preventing preterm birth, perinatal outcomes in singleton cervix, and this is a meta-analysis. Interesting that this is not a meta-analysis, not study, but of individual patient data proved from all the studies. It was vaginal progesterone is certainly a significant reduction in the risk of preterm in 33 weeks of gestation. So has all the other beneficial of preventing that preterm birth. If you look at this study, which compares progesterone to cervical cerclage, men who have previous spontaneous preterm birth and the short, you will again find that there is hardly any difference between vaginal and cerclage. In fact, I remember a time when guidelines did not recommend cerclage, which now, as I will show you a little later, seems that vaginal progesterone is quite. Then you have this other study which compared progesterone 17-OHP cerclage through systematic meta-analysis, and it points out to progesterone was in fact intervention with consistent effectiveness for preventing preterm birth in pregnancies overall and in those with birth. In fact, another interesting, if you will, a side finding, if you will, progesterone is associated with a lower vaginal GBS colonization, 17-alpha hydroxyprogesterone cap. Really a bit of a counterintuitive finding, if you will, but it is there. I think it is all the more to show that vaginal progesterone could be a method of. A lot has been said about dydrogesterone of pregnancy and immunomodulation and so forth, but I'm afraid that dydrogesterone in fertility is as efficacious as the Lotus 1, Lotus 2 trial said, non-inferior compared to vaginal MVP or recognized progesterone, but we simply don't to comment on this one way or another. So let's look at what the RCOG guidelines, which updated, say. They essentially say the history of spontaneous preterm birth, weeks of pregnancy, or a mid-trimester loss. A transvaginal scan between 6 weeks of pregnancy that show a cervical length of 2.25 centimeter or less. You a choice of prophylactic vaginal prophylactic cervical cerclage. And as an Indian, I'm always happy to see of cervical cerclage, being accepted worldwide. If you are going to progesterone, you should start treatment between 4 weeks of pregnancy and continue until at least 34 weeks. On the other hand, you had patients who have and also have had preterm membranes in the previous pregnancy, trauma, then you should offer them cerclage and vaginal progesterone, preventing preterm labor. If you have put in a switch, you need to ensure that a plan is in place for removal of the seed. These are some European guidelines. I iterate the same thing. Maybe the values go up and down a little bit. So they say cervical shortening 1, the RCOG which says 2.5. But the essence of the recommendation, which is that you should use, and it could be effective for preterm birth. Unfortunately, despite all these recommendations being out there, not everybody. So I think programs like this, webinars like this, could be a quite effective professionals aware of the using these medications to prevent and even mortality, which is a maturity and preterm labor. In this presentation with this quote from Winston Churchill, who wrote that I passed from the tossing sea of cause and theory, firm ground of result and fact. That we are now somewhere here, the firm ground as far as progesterone for preterm, and I do hope that I've helped to. Thank you very much.
So much, sir, for this extensive presented and for your so clear-cut take-home messages, which give us a way forward as to in cerclage and when to use progesterone. I invite now Dr. To please sum up regarding a few words.
See, there's Dr. Pradeep Suryavanshi, and both they are really excellent academic wise also. Pradeep Suryavanshi has narrated, and the statistics was when to treat the baby, when to start the level, the statistics about when to counsel them, liver care after weeks, after 28 weeks, and all that. And Jaideep Tank is a really actual sixer. His track record, but just I don't want to explain. One thing is that he is add to his biodata. He is FM, FH. I know, but we know Foxy only human. He is always ready for Foxy member. Thank you, sir. Thank you. The two talks are really excellent.
For
Thank
giving
you so
us
much.
such valuable.
And he's a born obstetrician, and given a talk with messages to all the obstetricians when to use NMP, when to use diet, HP, role of circulars in clear and crisp manner. It was an excellent talk.
Thank you.
Thank you, madam. Thank you, sir.
Team chairpersons for chairing this session. And now I hand over to my co-host.
I would just like to persons for their wonderful comment. Me and Pardeshi sir and by Suryavanshi sir and Jaideep, thanks for joining. Worried when you went away. And I would like to that we have been now joined by faculty. They have already joined with some time ago. Dr. Mall from Monash University, Dr. Firdausi Begum, and Dr. Rodrigo Ayla, Secretary Association of Perinatology. Welcome to you all, and I hand over again to Priya.
This opportunity to say hi to Dr. Hello. Here.
Thank you, Dr.
Good afternoon to all.
Yeah, so I would like to take on with the important addresses that we have from two of our very eminent international. So to chair this so very important, three very eminent Foxians chairing it, and first of all, it's Dr. Sir. Again, he is the Vice President of Foxy. Past President of Foxy, Vice President 2019 to 21, and I will say over here that he is associated organizations of the world, and he holds important posts in most of. Welcome you, sir. I think that's the best introduction because you truly hold that position and you're such an enigmatic person. Sir, to this platform. Our next.
Thank you very much.
Chairperson is Dr. Anita Singh, ma'am. She is an ex-professor of the Patna Medical College of Foxy, past president of the Patna, chairperson of the Endocrinology Committee from 2014 to 16. Contributed a lot to many books as well as she has articles in many journals. So I welcome you, ma'am, to this platform.
Thank you,
ma'am. And our third chairperson is Dr. Parag Biniwale, sir. Again, as the picture clearly depicts, a ever smiling person and always very and answers whenever, at whatever time it may. Here is the present secretary of. He is a senior consultant in Pune, unit head and PG teacher in Kamala Nehru Hospital, and he is of the Menopause Society Pune. I welcome you to this session.
Thank you.
So first of all, welcome Dr. Narendra Malhotra, sir, to keynote addressee. Dr. Fed, she will be talking on hypertension.
So very good evening to all of you who are attending this. It's indeed a of this conference, a lovely, fantastic talk. Despite of two other conferences going, seems to be getting a lot of crowd. It's my great pleasure to introduce my president of CEFOG, Professor Firdausi Begum. This year, and I was a secretary, the professor and head of Ibrahim Medical College, Builder, and the president of the South Asian Federation of OBGYN, CEFOG, elect of the Obstetrical Gynecological Society of Bangladesh, subcommittee of SRH under SEER Time Children Health WHO. Ferdowsi will be talking to us about hypoglycemia and pregnancy and preterm births. Madam,
Thank you so much. Good afternoon, and me and for this kind, and hi to my Indian friends and my co-host, learned co-host. Let me share my. Yep. I think I'm able as well. So I aspect and why I have selected that presently Bardem, which is I think the hospital in the world, which is situated capital. So this is I wanted to share my observations. Know that 16% of births have hypoglycemia in pregnancy. IDF data, and 80% of cases being due to GDM. We know this as well, that the diabetes, gestational diabetes and over diabetes, many forms of hyperglycemia like type 1 and type 2 diabetes mellitus. See, over diabetes during pregnancy and gestational diabetes with insulin therapy. Is the which shows that GDM varies from as 2 to as high as 31. This is the incidence of our, which varies from about 10% of pregnancy. And again, a number, South Asia represents a lot. In the second, which has the highest number of diabetic patients. So coming particularly to hypoglycemia and prematurity, and go back to the very famous HAPA study, where we see premature delivery, among many others, are very important. And all the odds ratio are high with very significant 95% confidence interval. And this is visible, and the next few slides are on this and some other aspect of this. So this is the follow-up done in 2012, where we again see that the premature delivery is important to maternal blood glucose level, both 2 hours after postprandial, as well as with hemoglobin A1C. So, and being complicated by clinical hypoglycemia and preeclampsia with comorbidities. So that's much graver. About type 1 diabetes mellitus, we see that the risk factors, including age, these are odds ratio, nulliparity hemoglobin 7%. These are all important factors which are related to not only spontaneous but indicated preterm delivery. That in mellitus and GDM, we need to terminate the pregnancy of an increased rate of indicated preterm deliveries. And the same study shows preterm delivery range from 12 to 22 women with type 1 diabetes mellitus. It increased 4 to 8-fold over the frequency of preterm delivery in single pregnancies. Either spontaneous or indicated, and rate of both spontaneous and preterm deliveries increase in women with type Spontaneous preterm delivery due to preterm labor or membrane has been associated with poor control and urogenital infections. Preterm delivery has been primarily related to occurrence of preeclampsia in women with diabetes. But we will be seeing that complicated independently as well. This is important. This is another study which shows that it's about very preterm births in gestational diabetes mellitus. This is a, and see that rate is, and there is no difference in mortality parameters on non including bronchopulmonary dysplasia, prematurity, and retinopathy. So this, according to their data, very preterm delivery occurring in women with GM offer an increased risk of neonatal compared to non-GDM. This is second trimester hyperglycemia. So this study shows that second and third trimester pregnancy hyperglycemia, second and third trimester is related to prematurity as well, and this is significant, quite significantly related. Second, and if we about the comparison between the risk factors of premature in the groups, like premature delivery, we see that hyperglycemia pregnancy group has quite significantly high p-value. Similarly, if we compare, I think the two factors or one is multiple perinatal infant, the second hypertension. It is followed by hyperglycemia group. So that this is so important, and we need it. This is the in type 1 diabetes mellitus in Taiwan. Where we see that we see that the power of the study is quite high, and here also we see the increased rate of in relation to diabetes mellitus. What about lesser degrees of glycemia? When glycemia is higher, association is more, but even the grade of hyperglycemia, see that the rate of prematurity is high. The risk of spontaneous preterm birth increases the pregnancy glycemia. This association of the perinatal complication that could have delivery. So we have to that we need to be vigilant about it. Again, diabetes mellitus birth with regard to spontaneous preterm that has been also proved that indicated, but continuous preterm birth so higher in GDM. This is again a study where we see that diabetes mellitus, they have clearly depicted pregnancy complication and risk factors for and gestational diabetes mellitus. Of course, preterm is the risk factor for preterm birth as well. So I was the increased rate of preterm birth gestation. Now there is another question which, and especially our junior colleagues are hesitant about it, to use the fetal antenatal for fetal lung maturity in patients. So I think a place where this needs to be more instead of being afraid, because the rate of ARD is more here. So diabetes contraindication, use tocolysis. And women with insulin-treated diabetes who are receiving steroid for we need to give additional an agreed protocol and monitor them. What we do, we titrate, but we have to be alerted that the insulin requirement of the patient, that is the only factor, and that has to be controlled. What about pediatricians? So this shows that what neonatal complications should be aware of in case of maternal gestational diabetes, and here comes first, in addition to aspect of neonatology to be managed. Here, it's the other way around prematurity. Disorder, we can say that the low and premature birth are both associated. So we have seen that in diabetic patients, has increased after, but the babies are likely to have type 2 diabetes in their. So this is a study where this is from midwifery, quite a good number of cases, and these patients were adult persons were given glucose tolerance test, and the prematurity seems to influence the risk of diabetes mellitus via attenuated insulin and independently threats. Similar many studies I have mentioned a few. This is the birth cohort of 30,000 between our part of 19th century. The result shows of the subject had received special reimbursement after age of 4. Subjects basically they got a reimbursement, that's why they turned up. Subject born before 35 weeks of ratio for diabetes was 68% with 6% CI compared to those born at term. After birth weight related to length of gestation is quite high as well. So they say that the preterm birth before 35 is associated with an increased risk in adult life. The risk of that associated with slow fetal growth. So it's only sometimes here, but prematurity itself is a red word that person may have that in their life. And this is from this as the baby born premature having diabetes in more likely. So with this, I like to conclude that in delivery and neonatal asphyxia in people with especially with hyperglycemia after pregnancy, with regard to the predictor of prematurity, this imbalance of hyperglycemia a more significant factor of GDM. So it's not only GDM, it's uncontrolled. If it is uncontrolled in the later part of pregnancy, maybe more risk preterm delivery. This implication for antenatal counseling and is to prevent adverse birth outcome. And then again, type 1 remains a significant disease threat, threatening pregnant women, and we must be aware of this. Preterm birth before 30 is associated with an increased risk of diabetes in adult life. The risk is associated with slow fetal growth and the excess of impaired glucose regulation very early age onwards. For the pediatricians of maternal health prior and during pregnancy, to pediatricians to anticipate neonatal adverse outcome. Low-income countries like us are insufficiently structured with screening and care to diabetic mothers. such increases the birth fetal and neonatal outcome and probably underestimated. And finally, counseling, screening for hyperglycemia, thorough counseling, delivery, newborn care, and postnatal for prevention and treatment of hyperglycemia and reduce its consequences. Thank you all for, though we always know that in webinar, multitasking, but still that I'm happy that some of you have listened.
Thank you very much, Begum. It was indeed an of problems of premature and gestation. Very rightly pointed out that SAFOC countries, especially India, Bangladesh, diabetic capitals, in facing a lot more patients than we were. Just one point I would have really brought out nice, the delayed development of organs. Even if gestational diabetes mellitus patient at 13 weeks, at times there is maturity which is delayed. We find that the babies turn out to be 37 weeks, and in fact the lung maturity also many, and these babies do land up the problems related issues. So thank you very much. And Priyankur, can we have the slide for the next speaker?
Yes. Well, I would like to thank Firdausi ma'am for such an excellent talk. I would like to, sir, in case if he wants to comment, stop please.
Thank you, Dr. Fully explaining what GDM harm do to the mother and to the baby. It's indeed a task for the SAFOC to combat this great menace. And hope in the next 10 years we will probably conquer the NCD. Thank you.
Moving on now, we have another very important speaker, Dr. Ben, professor at the Monash University, Australia, and he'll be talking on newer and traditional and limitations. I request Dr. Parag Bini introduce him, and then we move on with the keynote address.
It's a pleasure to introduce Professor Ben, Professor of OBGYN at Monash Medical Center, Victoria. He was professor at Aberdeen Research University of Aberdeen, UK. Been editor of European Journal Gynecology and Reproductive Biology. Tocolysis is something which is a controversial issue, and I'm sure Professor Ben will throw a light and give us clear messages. Over to you, Professor.
Yeah, thank you for that kind introduction. I'm going to share my slides and then just want to that you can see them well. Presentation. Is this okay or not? I don't hear you.
No, sir. You need to put it in the slideshow mode.
Slideshow.
Yeah, I do it again. Just a moment, I apologize. I don't get my own presentation in the, oh, there it is, I think. Now it says screen sharing.
Actually, you need to share the particular extended display now. So just select and don't put it in the window. Or you may forward your PPT to me.
I think this should work. Now I go to present. I got it.
No, it's a window.
Okay, I'll try it one more time.
Perfect, perfect. Please go ahead.
So thank you very much. This was an unexpected from Dr. Priyokan Roy. We've just met, I think, a week ago, but I'm excited to be here. Conference actually in today, so that's how it's going in the time. You stay in Melbourne, and then 2 conferences. So I was tocolytics and new and traditional tocolytics. I'm an advisor of it is a company that is developing a new tocolytic. I have one slide on. Redefined as 37 weeks is a global problem. Prevalence 7.7% in the Netherlands, country-wide 0.4% in Australia, 7% in China. The number 2 contributor to child age of 5, and there are strategies, prevention. That's what the previous speaker, one of the previous speakers, and in case it is becoming symptomatic. And I just in preparation of this lecture, India actually has the largest amount of preterm birth babies born each. And you can see that here, 3.5 birth in India compared to 25,000 in Australia. Tocolysis is 1964. That is basically indicated by needed if you delay birth, that will lead to a better outcome. Slide where gestational age increases and then neonatality and morbidity, and that's obviously a good thing. Then that you can delay the moment of delivery that is supposed to improve the. This is development of relaxin, indomethacin, nifedipine, that later on Barusaban that never to the market. And here is an important point in time. That is the introduction of in 1972. The unexpected discovery done by Liggins and Howie, who were studying timing of birth to sheep, and then observed that the lambs that were born premature after that steroid administered did better. Led to a randomized clinical trial in Auckland, published pediatrics. Interestingly, not Lancet was not interested at the time, and he basically showed that giving steroid thing for babies, and that means there is an additional because it means that if we can delay term birth for 48 hours, actually doing good. He's a hero obstetrician and guy that we should realize that tocolysis is for its maturity, and that we thinking about tocolysis maturity than we have done thus far. The history of tocolysis consists of premature action, premature thoughts. If you look at randomized clinical trials in the topic, then that is actually very rare. Apostle 3 number of randomized topic to date 24, which is actually very, very. And this is the series of Cochrane review. So a lot of comparisons made, but realize that this comparison from one to another. So if you try to express the success rate, delivery 8 hours prevented, that the agonist, antagonist, calcium entry block, and but they do not report sufficient way on neonatal. This is a analysis is in BMJ by David Haas and colleagues, and a net analysis means that different interventions are compared at the same time. With a tennis ranking, where not a tennis player plays another, you can say who is the best tennis player, etc. How network meta-analysis works, basically see that as placebo, all the tocolytics seem to work, but rather there is not a clear delay of the delivery 48 hours. If we look at neonatal mortality, the relevant endpoint, then you comparisons versus placebo are going to not show statistical results. So this network needs to summarize in most of the literature proves that there is a delay of delivery of 48 hours. The calcium antagonists or prostaglandin inhibitors, but it does have a positive effect on first neonatal outcome. And harm. What I will do now is you a series of studies in the Netherlands under the acronym Apostle studies. So what we did, a series of studies, all evaluating, and we'll discuss them. So the first one, it's an RCT, but it's a cohort that evaluates Apostle 1. Oh, sorry, that whether so that's Apostle 1. Cervical length measurement and fibronectin testing can be to identify when going to the fetal fibronectin, potentially a good test. Evaluate, and we found in our study, if you had a number of patients in that study, that if you had a short cervical length, under 20 millimeters, 15 millimeters, that your delivery was very high in fetal fibronectin status. No need to determine fetal fibronectin. And if your cervical length is over 30 millimeters, then you're not going to deliver. So what we basically can say is that we women with threatened preterm, first with a cervical longer than 30 millimeters, we can maybe remeasure. Under millimeters, high risk, between fetal fibronectin can help. Positive fetal fibronectin, high birth, negative fetal fibronectin, reassuring. What the impact was tocolysis. So I don't know your criteria, but what we did is we randomized that gun to 2 doses for continuing of that, or with nifedipine, and we basically no difference from that study. So I think this study indicates that if you use the and we have added up with other studies that there is no effect. Then found out who to treat when that long maintenance tocolysis was not effective. We compared nifedipine in the Apostle. So we did find the primary outcome. We found perinatal death in the atosiban group. So I'm curious to hear from you, nifedipine, but basically significant, comes closely a harm and a very serious harm. So I'm concerned about these data. Also found is that nifedipine is the better tocolytic compared to atosiban without Then we looked at tocolysis with ruptured membrane versus placebo, and we randomized a relatively small number of patients, but we basically found no effect. And I don't think that tocolysis treatment in women with ruptured. Then people considered to do that tocolysis progesterone. That is in other studies, one from France, and so in women who come with contraction or otherwise have threatened preterm birth, reason to start progesterone. We have assessed giving a pessary arrested preterm labor. We have not found an effect of a pessary. So there is no reason, if somebody comes with after that a pessary, and I consider it even that women are going to contract, it could potentially harm the cervix and cause complications. There's a Spanish indicates a slight benefit, but I'm convinced for the use of pessary with threatened preterm birth study a positive effect of studies. A good diagnosis of threatened preterm labor is realize that if you're going to treat women who are actually not preterm birth, you're not going to help them, they're not going to deliver any, and you potentially harm the baby by giving steroids. So I think it's to have a good algorithm, diagnose or to agree how you threatened preterm labor. Then I data that maintenance tocolysis, and there are that maintenance tocolysis. Tocolysis doesn't help in women with PPROM. Nifedipine and ato have similar outcomes, but nifedipine potentially increases neonatal mortality. Nifedipine is a stronger tocolytic, it's cheaper, and atosiban safe. Then this study was published in the Lancet, and the Lancet said in an edit comparing that study that we randomized studies treatment to placebo. Unfortunately, we don't have one study that compares atosiban versus placebo. You can see it here from no benefit from anything. There is potentially a harm. Studies that are there for versus placebo, there are RCTs on that. Is that a problem? Yes, potentially. Nifedipine can generate hypo. This is a case report of a baby after the was given nifedipine. So where does nifedipine actually come from? Made by the company Bayer. It's not made for use in pregnancy. Tocolytic drug. It's used to treat people for hypertension. So a colleague Lamont wrote to there and asked them have a license for use in pregnancy. Answer: does nifedipine have a license for use in preterm labor? Answer: what's the evidence to support the use in spontaneous preterm labor? Small investigator-led studies. The worries about safety, list of by Bayer. What have you told regarding the recommendations of nifedipine? Recommend nifedipine and go to the RCUG in case of responsible clinicians, not Bayer. So this is for where I work in Australia and New Zealand. Women prescribed to women with threatened about 20,000 times a year. This drug that have never to be tested for evidence of a positive baby. So this is where we are. The big categories of tocolytic drugs: beta agonists delays delivery within 24 hours. We don't know if it improves perinatal mortality. Same counts for oxytocin antagonist, calcium blockers, and indomethacin, cyclooxygenase inhibitors. Also no proven effect, although I think that this potentially one of the stronger tocolytic. And this is the guideline from WHO. The use of tocolytic treatments is women at risk of imminent preterm in the purpose of improving neonatal outcomes. So we don't have, so we should develop them. But unfortunately, development of drugs in pregnancy is a very, very complicated setting, because one, small, and two, the risk for the manufacturers are high, so they usually stay away from it. Fortunate to work with a company Opsiva, invest in these type of programs, and I'm also excited to say that we have a phase 2A study in synthesis inhibitor that potentially shows the capacity to delay pregnancy with more than study is not published yet, and will maybe submitted at presented at the society from later next year. Sadly, best in research in are struggling. This is GSK that has invested in the program and was not successful. I was informed that you use isosubrine hydrochloride.
Reminder for 2 minutes.
Yeah, okay. I'm almost done. Which is not a randomized study, so I would encourage you to involve a randomized study. So I come to a conclusion. I discussed the Apostle studies. We are doing currently the Apostle 8 study in the Netherlands. That is a study comparing atosiban versus placebo. So here we're going to do studies compare with placebo. And the question here is atosiban is cost effective a neonatal outcome. I'm quite skeptical. I'm not sure that if we 12th apostle here pictured, that it turns out that the name of that 12th apostle, Judas, tells us something about the effect. Not sure whether it's truly effective. The effectiveness of tocolytics is not proven. WHO and placebo-controlled studies are needed. There is hope. This is published in the New England Journal of Medicine on steroids. So that was a study that basically repeated ligands and Howe finds a positive effect, and it finds it specifically in women who get tocolyzed. So potentially you could say that delaying delivery with 48 hours is a good thing. You can also see that on this slide, where treatment effect of steroids increases if the time between giving and delivery is longer, and that tocolysis. This is my last slide. Day without randomization progress. I give the word back to the chair to answer any questions. Thank you.
Thank you, Professor Ben. And I think Dr. Anita Singh is going to make a small presentation, and she's going to share some experience from the Indian subcontinent about use of isoxaprine in management of preterm labor.
Thank you, Dr. Parag, and thank you, Dr. Ben Moore, for sharing with us regarding your that are in the pipeline in the research, and we are very hopeful for those to be. Can I share my screen? Now I'm going to share some of the Indian studies, because I think isoxaprine has not been included
Please
in
put
the
it in
new
the
drugs
slideshow
that
mode.
Dr. Moll. Hello?
Please put it in the slideshow mode from beginning.
Okay. Actually, it is not doing.
You go to first slide, and then just on there is a column there where you can just click and it will come as a slideshow. Right now we can see your full presentation.
Just approve my request.
Okay. Okay, got it. Okay now?
Yes, yes.
So if this has already been said by Dr. Ball, so I am going to talk only regarding isoxaprine. It's a beta with sympathomimetic have been most frequent in preterm labor, and it was the first beta agonist to be used to, but it is a potent vasodilator, and it is a drug which is approved by DCGI. And ACOG also recommends beta sympathomimetic as first-line treatment in the management of preterm labor. What is the dose of isoxaprine? This is given as IV infusion, 4 2 milliliter ampoules in 500 dextrose or ringus lactate. The dose we start is 8 drops per minute and increase by 8 drops per minute every 15 minutes till the uterus becomes quiet. But the maximum dose should not exceed 0.5 milligram per minute. And one should monitor the BP continuously at the time of initiation, decreasing the dose of isoxaprine. It should be titrated. IM injections are onset of preterm labor if there is no facility for IV, and it is given at a dose of 10 milligram every 1 to 2 hours. Oral administration after the uterus has become quiescent, and the dose for oral administration is 60 to 80. But we know that there are dizziness may be there, but the most dangerous ones are low blood pressure, palpitation, tachycardia, So we should be very careful regarding the pulse rate and the blood pressure of the patient when we have specially put her on intravenous drip of oxytocin. And side effects, but they are not very serious ones. It is only the CVS which is affected in some patients in a very bad way. We should be careful about that. There was a practice pattern study from India under Dr. BP Raju, and they had studied on 285 patients from January to December, January 14 to December 16. And it was seen that 60% of the obstetricians in India is using for the management of preterm labor. And maximum patients received, or some of them received even intramuscular, and few received oral dose in the doses that I have just described. And when they looked at the maternal outcome in relation to gestational age, if it was less than 32 weeks pregnancy, there was maximum benefit with isoxaprine. This was a comparative study between isoxaprine and the days which were gained were 36 days, whereas it was only 1.44 with nifedipine when it was 32 weeks of pregnancy. Regarding the mean birth weight, 2 weeks, there was improvement by the average weight was around kg, whereas with nifedipine it was only 1.07. So this study showed that if the labor starts before 32 weeks, and if it is detected early and you start with IV drip and then continue with it, you can gain many days in the continuation of pregnancy. There was another study which has been published in American Journal of Perinatology in 2019. This was again by Dr. B. Raju from one of the medical colleges in Karnataka, and it was a single, and the same he was very strict about inclusion and exclusion criteria, excluding all those PROM, multiple pregnancies and all that, and dose was implied in this study also. And it was seen, he started IV drip when there were 3 fractions in 20 minutes, and it was seen that there was a good amount of gain if there is in the weeks it reached up to 31, and the latency period was around 58 days when it was started before 32 weeks, and fetal birth weight was also 2.7 kg, Apgar 5, and at 5 minutes it was 9. So he concluded that successful tocolysis was achieved in all patients. It was 2.7. There was again a survey done by Indian Consensus, documented by ISSRF, and it was 113 practitioners were surveyed, and 75% of them used isoxaprine in their clinical practice, and 94% used in preterm labor, 63% used as prophylactic agent in pregnant women at risk of preterm, and it was also given as a prophylactic along with cervical cerclage. There was another study from Giorgino. It was a meta-analysis of 25 cases from different countries, and they also concluded that it has got a good effect upon preterm labor. But they reported, this was one study where they reported adverse events, 13.9%, hypotension 5.7%, nausea and constipation. So they have reported very authentically the side effects that they came up. So there were recent tocolytics update. Beta biometics decreased the number of women 48 hours, and there was decrease in the neonatal survival within 7 days. Etosiban is no better than placebo in 2014, and calcium channel were recommended for preterm labor. But progesterone, there are several new studies which have been presented already today, and also recommends in its TOG6 recommendation that for threatened preterm labor, immediate measures are for 28 hours parenteral isoxaprine, or one can go for etosiban along with corticosteroids and Maxulf. Yes, one can start with isoxaprine, oral 17-hydroxyprogesterone injection. In established preterm labor, established preterm labor more than 4 centimeters, go for delivery. 4 centimeter, you can try with tocolysis with parenteral isoxsuprine. So I have to say that prematurity contribute to parenteral mortality and morbidity. Isoxsuprine and etosiban are DCGI approved drugs in preterm labor, and isoxsuprine is preferred and the most commonly used tocolytic in India in several studies we have seen. And it is administered intravenously and taken over by intramuscular or found to be safe and well tolerated in the studies with the precautions that I have talked about. Still need many trials comparing its side effects with the newer molecules that are there, but nifedipine is not in India for in preterm labor. So here my just wanted to share the this Indian perspective that I came across, where its use is quite prevalent in our country, and there are many studies on that from our country that has come out. Even the TOG6 recommends it.
Thank you, Dr. Anita. Priyankur, I think we are running already, so I don't think we'll have time to entertain questions. So thank you very much, and thank you Dr. Kalyan Barmade and the entire team for having all of us here. Thank you.
Thank you, the chairpersons. I would thank Dr. Ferdowsi Begum Madam, Dr. Benmol sir, because they have to be here half an hour before their talk, and in spite of that they have at their country in Australia as well as in Canada, where MAM is currently there. So thank you so much for delivering this keynote addresses, and also thank to the chairperson. I would request Vaishali ma'am to say a couple of words.
I would like to thank our chairpersons and Malhotra sir chairing this so well, and Anita ma'am for your inputs about isosuprine, and our speakers, our international keynote address speakers. Thank you very much, Dosi ma'am and Professor Benmol. It was a pleasure and honor for us to hear you. Thank you very much. So Priyankur, over to you.
Dr. Vaishali. Now moving on, we have, I would like to mention over here that we currently have 1,500 delegates present with us after 3 hours of this scientific program that we still have, and we have other conferences also going on at the current time. I can understand, of course, nowadays there are so many webinars happening, but the scientific content is the utmost usually people look at and they join the conferences. So moving on to a highlight of today's conference that we are having, the oration to be delivered by none other than the Secretary General of the International Association of Perinatal Medicine. And for such an have our none other than our Foxy Gandhi sir, who will be moderating the session. And along with him, we have Dr. Rishikesh Pai sir, Dr. Suchitra Pandit ma'am as well, who is the past president of Foxy. Ma'am is the president of ISOPA from 2018 to 20, president 2015 to 18, and also the president or the chairperson of the ICOG. She was the Foxy representative to AOFOC from 2015 to 17. So Rishikesh Pai sir is our president for the year 2022. He is the director of IVF centers and has performed more than 20,000 ART procedures in the past 25 years. I would also like to congratulate the conference that is happening simultaneously.
Thank you.
So moving on now, I'd like to request Dr. to kindly introduce Dr. Rodrigo Ayla sir, and he'll be talking on hypotension and the current numbers. Are the current numbers good?
Thank you, Dr. Priyankur. On behalf of myself, Dr. Suchitra Pandit and Dr. Rishikesh Pai, I for this very, very important session of International Foxys in conference on perinatology. I agree with Priyankur that in we have a very good number of registrations are attending this conference. Oration is awarded to Dr. Rodriguez, a member of the American Gynecology since member of American Gynecological Laparoscopy since 2000, Secretary General of the World Association of Perinatal Medicine since 2019, International Academy of Perinatal Medicine 2015, member of society since 2013, and Secretary of the Association of Perinatal Medicine. We can say he is an international topic, and we are going to have a very interesting for his oration. In pregnancy are the current for everybody, and in India we all hypothyroidism is endocrinal disorder after diabetes mellitus, facing mainly three disorder: diabetes and hypothyroidism and PC, and it has a significant effect on pregnancy. Let us see what is the recent, what are Dr. Rodrigo would like to update us in his oration. With this brief introduction, Dr. Rodrigo for his.
Yes. Can anybody?
Yeah. Yeah.
Good. Good morning from Mexico. I know it's afternoon in. Yeah. Thank you very much for. I would very much like to thank the organizers. This very important. And well, I will start off with my presentation here. So. There, can everybody station now? Good. Well, thank you for the kind presentation. As it has been, hypothyroidism actually important position right on the affections of the. Now, and some of the actual situation. This is our region, and especially North America, composed basically of three countries, which is Canada and Mexico. The States, the most populated city, populated country. We're talking of 123 inhabitants. Therefore, the impact of hypothyroidism is 21 million. Mexico being the second most populated, an impact of 7.7 million in Mexico out of an estimated 123 million, and Canada being the biggest geographically country, it's the least with 24 million. The most important factors here is population is being distributed at the of the population. Groups which are associated with reproductive ages, we see the base is being narrowed in the United States. Can't say the same for as a very broad population, although in the last few years, population in Mexico have been quite successful, and the pyramid being broadened at the base. Still, we have a very significant, very population within years. And Canada is completely opposed. We have a very narrowing period at the end of the age here. Therefore, the baby boomers are the ones with the largest population, but now which are the millennials going into this age, it's a much smaller group. Mexico, especially since this kind of looking at various similarities. Yeah, looking at India's situation is the population pyramid is ours, and a very large population reproductive years. The risk factors are also, we're talking of the second in the world, speaking of population-wise, which is in inhabitants. The latest reports, I personally read this Indian Journal of Endocrinology, the latest, that the incidence is 4% prevalence in India. Therefore, this constitutes an estimated 146 million people with thyroidism, just is very, very significant. Now, the population at risk, the population we're talking about is females, low autoimmune disease, physiological causes of hypothyroidism, and the women within their reproductive age. Now, although we may have autoimmune causes for autism, still the greatest problem is the lack of appropriate iodine. And this is a problem going on worldwide, which the countries which lack a consumption of iodine. The World Health Organization recommends 250 micrograms, and these which fail to achieve this goal. Now, you can see that India, for example, Mexico, although they're which states here that their intake is achieved, once with these lines is national data, and is that we don't have a proper screening of the entire region. As far as I know, at least in Mexico, the concern here is that the information we're getting from urban centers where screening is much more adequate. Yet in other parts, especially rural regions, for screening system, it is we have a larger iodine diet in these populations with abroad, outside of the cities. We all know about the importance, the physiological importance of the T4 and T3 hormones. They're involved in thermoregulation, metabolism, and when we talk these factors, we're talking about energy. How energy is important for the proper and function of mitochondria and cell actions. Therefore, we all this concept into what is with our embryo, and later as it slowly develops. This is what constitutes the importance of the throughout pregnancy. We well identify different receptors for this hormone and how they act might disposition of glucose and other energy factors for the different body. Pregnancy, the woman is great deal of stress. Therefore, pregnancy about 15 to 20% increase in metabolic rate, and this increased due to oxygen, cardiac output adjustments, and vascular modifications. Now, if we take into account the amount of iodine that at the disposal of the body, we have a crisis here because there's an increased renal clearance. There is a low tubular reabsorption, therefore losing the women in the losing more iodine. It's an active secretion during breastfeeding. Now, the estrogenic stimulus increases the thyroid binding globulin concentration. This leaves there's no free hormone, the actual consumption within the body. Now, evidence of early pregnancy, and this is the need hormone in early stages. And so their thyroid have been found in the fetal tissues. And this is very important or very significant to the fact that this signifies the need of the thyroid hormone in early stages. Hormones have also embryos and membranes. And nuclear receptors found in the brain incredibly important, since we all know the great relevance have in neurodevelopment. And this studies in other species is required for neurogenesis and the transfer of that remains until birth. So the fetal might be producing their own hormone. These are not the amount or required by the fetus for. Therefore, they are highly dependent on the hormones synthesized by the mother. Also, excess maternal T3 the fetal brain, not T4 study, which was very interesting to observe. Therefore, this is a very delicate balance of the position of T3 for. So where does this thyroid hormone in neurodevelopment, which is one of the greatest concerns, as one of the greatest consequences with these that have their hormone insufficient, is cretinism. Although we do not want to get to that of the lack of hormone deficiencies, we might see neurodevelopment by the lack of proper. So this is neurogenesis and the migration process of the brain and of the central, and myelination is highly affected by thyroid hormones. Cell differentiation and the development of neurons. This will affect the cognition and could actually predispose a person to any neurodegeneration, making it more liable, prone to diseases that can actually neurodegenerate. So early hormone or iodine deficits with low IQ and cognitive disorders, lack of MACT8 that develop Allan-Heredon syndrome. Now, although studies need further to see large cohorts or babies having this brings us a very tricky where we cannot do these studies, and it's not ethical to be patients that might have insufficient hypothyroid hormone against which is an impossible problem. Now, major, especially when we talk about testing, whether we should, based on have this important population of hypothyroid, and what should we do? We test all the pregnancies, test all of our patients, like India or Mexico. Very important problem. This could be one of the solutions to this problem here, and this is why we have a agenda based on this deficit, and all the hypothyroid causes. Still, one of the major issues is when to test, when should screening. We must know this homology of TSH to HCG. Only the beta fraction is specific to the hormone. Might actually complicate the proper diagnosis. We see here in this publication, which is quite, we can see how G will have its peak around week of pregnancy, and a slide the TSH levels. Whether or not this constitutes a problem for thyroidism, many of these criteria and many of these screening tests is looking at TSH and hormones, hormones as the only parameter. There might be a lot of misdiagnosis, and because once after we go beyond week 10, we have normalization. The TSH levels will go back to and finally HCG drop that is characteristic as pregnancy advances. So this constitutes diagnosis. TSH termination T4 is still one of the most important to diagnose hypothyroidism, make us suspect the presence of a hypothyroidism situation. Risk factors associated, we know major recommendations here is to include anti-peroxidase antibodies and try to inquire about insufficient iodine diets. Now, the other problem is the test itself. When we talk about immunoassays, we might have a great deal of variability on the results. The geographical issues, which might be another confounding factor. Multiple gestations, they pose a completely different stress factors to the pregnancy itself. Therefore, multiple gestations should be addressed in a very sensitive and a very suspicious manner in order to perceive and to detect any alterations. And obviously be fully aware of the HCG levels throughout pregnancy. So other proposals for the tests, but the problem with these proposals is that they are not fully developed. They are too expensive to implement as a screening system is ultrafiltration, equilibrium dialysis immunoassay, mass spectrometry, or fluid chromatography. They might be much more efficient than the present immunoassays. Still, they're too expensive and too underdeveloped in order to make them a massive test as screening should be thought of. So we have the deionidases, which is other enzymes that are very the proper disposition of the required hormones, which is T3 and T4. And basically here we're talking about the impact that T3 actually makes. And if we look at it, how the placenta is a major contributor of some of these enzymes. And D3 tends to have a decrease after mid-gestation, increasing local T3. Now, what are these minimal amounts of deionidases throughout the pregnancy? Well, still, there's no biological significance for this. Therefore, it's still important to make proper research about. And well, the association of the hormones during the development of different central nervous system structures. We're talking about the cerebral cortex. As we advance through the weeks of gestation, we see these increases and how they are required throughout the cerebral cortex development and specification of the cells. This is a very important concentrations of the hormones that are actually increased during the very important phases of development, which are associated with the development of these organs. And proper supply of the T3 and T4 hormones is highly required. Now, other targets that might be interesting for future research are many of these proteins, which we've seen as plasmatic transporters in the placenta. Very exciting research is going on with MCT8 and 10, LAT1, but still there's more research that is required in order to see the actual impact of these protein transporters in the placenta, which might actually enhance the actual transportation of the hormones into the fetal circulation. Now, deionidase enzymes might also be a very interesting target for treatment if we could increase the activity or the disposition of these enzymes within the fetus. They could actually increase the number, the actual amount of the free T4 and T3 hormones available for the fetus and development. And well, there's other molecules which are also being studied, especially placental development, which is very important for our fetus, and they also require the thyroid hormone stimulus. So, what is the situation and how we are doing these diagnoses? And what is the great controversy in several countries, whether to screen or not to screen? So currently, we are looking at what the American Thyroid Association recommendations, and these are probably the recommendations that are most widespread in the world, especially in our hemisphere. They're the recommendations which many countries are following, and we can see here. There we go. The criteria. So for proper diagnosis, what the criteria is, if you're looking at a hypothyroidism as a diagnosis, you've got to see TSH elevation and low T4, especially patients which have Hashimoto disease. Then we have the subclinical hypothyroidism, which is incredibly frequent, TSH elevation with normal T4. These are the patients which we have to observe closely throughout pregnancy. We never know in what moment they can actually develop an overt hypothyroidism. Hypothyroxanemia, normal placental TSH levels with free T4 in the 5th and 10th percentile and below the reference range. Now in the United States, the actual numbers they're looking at in their population, 15.5% gestational hypothyroidism. And out of these, 97.6% is diagnosed as subclinical hypothyroidism. In Mexico, we do have the numbers for gestational hypothyroidism, which is 18.4%. Still, we lack the actual percentage of the subclinical hypothyroidism we might actually see. These are the numbers which I stress to you to look over. and we will discuss them further ahead because these numbers are being now questioned whether they're appropriate for every single population. Maybe we are overdiagnosing, especially subclinical hypothyroidism. And it's not required to give treatment to all these patients. Remember the actual toxicity that T3 might actually give or bear in our fetus. So first trimester, it is TSH superior limit is given as equal or under 2.5 micro units, milliunits. And a second trimester is 3 milliunits, and third trimester from 3 to 3.5 milliunits per liter. Or not to treat, to screen or not to screen, just like Hamlet had this situation, the famous play by Shakespeare. But does it actually diminish preterm deliveries? Does it diminish the abortion incidence? We do know that increasing iodine intake will further enhance hormone synthesis, and the entire hormonal situation will be improved. But what about the neurocognitive outcomes? This has also been questioned since some studies, especially in the United States, have seen that there is no major impact on patients that have been treated. And those that have gone undiagnosed, especially on subclinical hypothyroidism, after 5 years of follow-up. Therefore, is it valid to do the screening? Doesn't it increase false positives? And what is the economic burden of doing this? So as you see here in the title of this New England Journal of Medicine article, we can see how subclinical hypothyroidism and hypothyroxanemia in pregnancy, there are still no answers. We're talking of March 2017, and this issue continues to be addressed. Almost every month we see an article talking about this. When should we screen? Well, the screening window that has been proposed is after the HCG peak. So we're talking about good iodine receptivity. And this might be the window right here between 10 and 14 weeks gestation. A problem we have in Mexico, and I don't know if you have it in India, is that many of our pregnant women actually go for their first prenatal visit or consultation with some medical service we might provide up until 14, 15, sometimes they even walk into the office as late as 20 weeks gestation. Therefore, this screening window is useless. We have other factors that don't make them like a very proper period in order to perform the screening testing. And we see how gestation further advances. There's a greater impact, especially during the maximum cerebral growth phase, which is going to be in all this entire period. And obviously, there's this important T4 dependency in this period alone. Therefore, the importance of screening at very early stages of gestation must be a priority for anybody who's trying to screen what the situation is with the actual iodine or thyroid hormones. So screening, many of countries and organizations are proposing to do only screen the high-risk patients. What is the percentage of success? And universal screening, well, we obviously know we might have a lot of false positives. The trick here might be to actually look for combined risk factors as well as the screening test, and maybe in some near future we might have better performance tests to do the universal screening. Now, we do see the importance of the screening though. We have various evidence, as you can see here in the Journal of Clinical Endocrinology and Metabolism. If we only see people with the risk factors, we're getting a population of 413 diagnosed hypothyroidism cases. And this is 26.5%. As opposed as a full screening, 100%, we're getting about 73.5%. You're actually missing out in about 30% population. So there's 30% of these women with hypothyroidism that will be lost. We will not see what the actual performance of their thyroid is. Another study, this is in Europe, the European Journal of Endocrinology. Universal screening detects 2 times more thyroid disorders in early pregnancy than targeted high-risk case findings. So they evaluated the screening in high-risk patients for the detection of hypothyroidism in early pregnancy. And as you can see here, only the ones with the risk factors, they came to 45% as opposed to the total screening, which is 55%. Also, we're looking at more patients being diagnosed, and they actually are targeted for treatment. So in conclusion, if screening is not performed with TSH, with free T4, and as I mentioned, the antibodies for peroxidase, at first visit, one can risk losing about 55% of those patients with thyroid pathology. Peroxidase actually gives us a greater certainty of what is going on in the thyroid. Therefore, at the end, they conclude that they do recommend the universal screening. And then this is another article from the Journal of Clinical Endocrinology and Metabolism. Universal screening versus case finding for detection. And this was a larger study with 4,562 patients, looking only at the cases found with 2,282, the ones with the high risk factors, the low risk factors. We take into account a larger population with low risk factors, as well as in this one right here. And we do see the percentages of the actual screening that are not being performed with only high risk. We would actually lose a greater population. We are screening, we're actually detecting 62.96% of these patients with hypothyroidism. And then the other universal screen, we have hypothyroidism with 69.84. So the numbers are pretty solid and pretty similar. Therefore, if screening is not performed, once again, to all patients at a prenatal visit, nearly 69% of the patients with thyroid pathology will be lost. And this proves that that in patients with risk, only validating or only looking at these patients with risk factors, we miss an adequate detection of patients with thyroid disease. Risk factors, these are the ones which have been accepted as the risk factors we should look for: family history, thyroid surgery, hypothyroidism symptoms, the presence of anti-peroxidase antibodies, head and neck radiation, advanced maternal age, diabetes in most subtypes. In this case, they're mentioning the type 1, but actually we should also screen for it. Patients with type 2 diabetes background. Infertility, recurrent abortion and preterm birth, and morbid obesity. So if we start at the very beginning of gestation, one of the impact factors that we do see is the recurrent abortions. So we have a higher percentage of mothers with abortions, which is 26% perceived by the mother, and mothers with 2 previous abortions, that's 3.2%, and 3 consecutive abortions, that's 1.5%. The age range, the incidence, well, we are clear that advanced maternal age is another risk factor. Still, the incidence of abortions associated with the presence of anti-thyroid antibodies is quite significant. So if the hypothyroidism is treated, the abortion incidence will go down to 4%. If you don't try or do anything to control this hypothyroidism, the abortion incidence has been associated with 31.4%, which is a significant difference here. Other pregnancy complications, Premature placentae, which we all know it's critical, and it always has catastrophic results. There's an increased risk which has been established with an OR of 2.83. What the cause is, ischemic lesion. We're not sure of the physiopathology about this and the associated, the exact physiological association of hypothyroidism. Still, it's a risk factor. The presence of anti-peroxidase antibodies. So we can see this in 70 to 90% of pregnant women with hypothyroidism, 30 to 60% in pregnant women with subclinical hypothyroidism. And we have situations like low birth weight, fetal suffering, vascular and placental complications, and abortions. And obviously, these are all also associated with preterm delivery. We see preterm birth, no increased risk for subclinical hypothyroidism. Though this is controverted, we don't know actually where to put the previous pathologies, whether they're associated with preterm birth or not, and whether we should report it as a preterm birth or as the actual pathology in itself that is being diagnosed. Preeclampsia, we know there's an alteration of the vascular and blood pressure controls by thyroid hormone, and therefore there is an increase of OR 1.6. So it's another factor. Now, screening, what's going on in the world, we do see that most associations, which are also related with the different geographical situations here, we do see that most of them do not recommend universal screening. They are recommending risk factors. We see this at ACOG, the American Thyroid Association, Endocrine Society, American Association of Clinical Endocrinologists, no screening, just individualized treatment per patient. Now, if we see the Spanish Association screening to all women, Asia and Oceania Thyroid Association screening to all women, and then we go back to the European Thyroid Association, which says only people with the presence of risk factors. So this is just confirmation of the complications associated. As compared with euthyroid women, women with hypothyroidism will have a greater risk of pregnancy loss, neonatal death, abruptio placentae, and premature membrane rupture, another important factor for preterm delivery. So we do see the importance of the situation here. And we do see how the thyroid hormone deficiency is a situation we've got to try and control because of the higher risk factors and the thyroid function test abnormalities, which we can see here, and the impact, which is actually significant. The peroxidase antibody testing results, which also favors high-risk factors being associated to this. And we should really look at the antibodies and how they're being reported. The problem is it increases the actual price tag on these screening tests. Now, what the outcomes are being with once we start treating the children, well, the problem with this is it cannot be proven. It cannot be proven that there's success once we give treatment, supplemental thyroid hormone treatment for the mothers and the children, and there is no significant p-values, although some studies have recommended the actual use of this treatment. So further research needs to be seen. As for the outcomes for neurodevelopment and cerebral skills and hyperthyroxanemia, it's also the p-value has not been significant in these studies. So for subclinical hypothyroidism for hyperthyroxanemia did not improve the actual results, cognitive outcomes in children through 5 years of age. And this is a very good study and a very significant follow-up. As for the evaluation of pregnancy complications, oops, sorry about that. We do see that they found basically the relative risk is most important on pregnancy loss, on placental abruption, and neonatal death. We got other significant numbers, preterm membrane ruptures, and gestational diabetes as a risk factor. So we also gotta skip this in order to come to the important parts that we want to see here. The risk factors that we do need to point out here are how gestational diabetes, but we didn't. There was no significant piece here. What we do see as a significant difference and a significant adverse perinatal outcome in subclinical hypothyroidism is in hypertensive disorders, which came to a very unexpected surprise. We were actually looking at other factors which might actually be more important. Still, the importance of thyroid hormone treatment must be focused in every single one of these factors because of the physiological associations. So what happened here with hypertensive disorders is there is a decreased nitric oxide secretion. Is there a vasodilation impairment that might be compromised due to lack of thyroid hormones? Or is there hypercoagulability in lipid abnormalities? Now that we've seen the facts of whether to test, whether to do the screening or not, then comes the great other question: what figures to use? What are our controls and our levels that we should use as the cutoff numbers for the population? Are those numbers the ATA is recommending adequate for every single one of our populations? And we've started to see that, for example, China has seen a significant difference in how their thyroid cohorts, hyperthyroidism cohorts, might actually have great fluctuation in their numbers. So we can see that when they use the cohort matching in 2010 with 825 patients, they had the thyroid dysfunction rate 29.1%. They have a match cohort with in 2014 with 82.4. So once they start using their own numbers, the results might actually change. And this is a study we're still undergoing in Mexico. And we see the numbers are significant as well. We see euthyroid patients it's our highest number with the total patients. But subclinical hypothyroidism is 139 patients were actually diagnosed with the present criteria that are the ATA numbers. So what's really significant here is we did not find a single patient with overt hypothyroidism. So these numbers might actually change if we try to see if these numbers are adequate for our population or not. It's been speculated that we might be overdiagnosing patients with hypothyroidism using these numbers here. Therefore, these are some of the factors we're looking at: the range of age of our population, mean values, And as you can see there, it's a pretty homologous population. And well, maternal complications we have observed also gestational diabetes and preeclampsia have been the associated pathologies in the population we are currently studying. So this one of my last slides here. We can see how using the ATA criteria of 2011, the action what the Chinese have found and how when they use their own criteria, what they have found. We can see that hypothyroxemia numbers go down when they made the adjustments to their numbers. And hypothyroidism also went down significantly. And the population that we are also screening, and we're having a great number of diagnoses, is the subclinical hypothyroidism. They also went down in their percentages. And we do have significant p-values. So the cutoff point controversy has also been addressed in a few publications. And what they conclude is the reference range for non-pregnant women can be used for the assessment of pregnant women at 4 to 6 weeks of gestation. The upper limit of serum TSH in the first trimester was much higher than 2.5 in Chinese pregnant women. Now, the Chinese are not the only ones reporting this finding. We are about to make a publication also making our findings, but similar publications have been made in the Netherlands, Turkey, and Portugal. So the criteria, at least in our population, these are the criteria in 2011 and 2017, and our numbers actually change. This is what the present study is at, 839 cases. And now we only have 100 cases with the new criteria 2017, the proposed ones, as opposed to 2011, which was a greater number, which is 300, almost 3 times the number of the present criteria. So we would like to, I would like just to give you some take-home messages. Undisputable importance of the thyroid hormones on initial and late pregnancy stages for adequate fetal development. This is obviously of great relevance. The determining the actual physiological TSH and T4 levels based on ethnicity and local risk factors. I believe that no physician can generalize their findings to the entire world. We should actually look at what works in our community and what does not. Pros and cons of screening and avoiding undetected complications versus overtreatment. And the major challenge here is to determine what the actual TSH and T4 levels are, as well as the peroxidase titles, the antibody concentrations associated with actual complications. When we try to do these screening tests, we should also always address the fact, not look just the numbers of the hormones, but what is the actual impact, the clinical impact, and verify screening cutoff values for your own region. So I'm very thankful for this great opportunity, very honored to be invited from so far, and I hope to sometime in a better situation to visit this wonderful country of yours, India, and also invite you to mine. Thank you very much.
Thank you.
Yeah.
Yeah, ma'am. Suchitra, ma'am, please go on.
Yeah. Thank you, Professor. We really enjoyed your talk. In fact, the oration covered up all the aspects of, hypothyroidism in pregnancy, and I fully agree with you. We have, for the last 2 years, been following the ATA rules, and we have taken the cutoffs exactly. And sometimes we find that we are over treating the hypothyroidism. So I think your take-home message was very, very important. Every region must have their own cutoff levels for the TSH. I'd like to just mention a very interesting study which was done in the western part of India, where they found that there were a lot of tribal women deficient in iodine, and naturally they had a very high incidence of goiter and recurrent pregnancy losses and preterm labor.
And in those cases, they actually found out, iodine patch in the form of a bindi. A bindi is a dot which is worn on the forehead. So these women were actually made to wear those dots, and they were provided with 30 bindis every month, and they found that the perinatal outcomes in those women were much more better. So that was a very interesting study, and we understand that the problems of hypothyroidism. And thank you so much, for the wonderful studies that you went in depth, and we hope that yes, we will see you sometimes in physical presence. We'll have you sometime in India.
Thank you. Thank you very much. Appreciate it.
I would now request Alpesh.
Any comment from Dr. Rishikesh Pai? Dr. Rishikesh will conclude.
Well, it's a fantastic lecture by the professor, and I think that we need to implement the thyroid screening more aggressively in our country. And that's one of the things which Foxy will try to strive to do in the future, in association with the Indian Association of Pediatrics as well. Thank you very much for a lovely lecture.
Thank you very much. Thank you.
Few words, Alpesh sir. Few words.
The excellent oration and very elaboratively and with so many good studies, data, and it is really, I can say, even eye opener also. And we'll definitely would like to, as Dr. Rishikesh has mentioned, Foxy would also like to work on it. And we also need some studies. A perinatology committee, you are doing excellent work, so you also can take up this project in India. So congratulations and thank you for this excellent oration. Thank you.
Thank you. Thank you very much.
Sir. Thank you, Professor Rodrigo, for being with us today. In spite of our different time zones, you made it on time for us. We appreciate it. Thank you, Alpesh sir, Dr. Rishikesh, and Suchitra ma'am for being here for the oration. Thank you. Thank you.
Thank you.
Thank you so much, Dr. Professor Rodrigo, and all the chairpersons, and also Vaishali ma'am for concluding such a wonderful oration. And it was excellent. And as we can see that we still have, like, the audience we can see the messages from the audience coming in, pouring in with such positive reviews about the talk. It's excellent, sir. So it was wonderful to have you here with us today.
Thank you.
Thank you. So now, so we move on to the to panel discussions now. And I would request my co-moderator, Dr. Diksha, to kindly introduce the panel topic and the moderator. Thank you.
Thank you, Dr. Priyankur. So after the fabulous oration, it's my great pleasure to invite Dr. Vaishali Chavan ma'am for the panel discussion today, which we are going to cover a case-based discussion on preterm labor with our illustrious group of panelists. Dr. Vaishali needs no introduction. She's the champion and the driving force behind the international conference today. And she's the chairperson of our perinatology committee, Foxy. She is the director of Gynae Sahadri Super Specialty Hospitals, Pune and Sanvi Clinic. She's a great postgraduate teacher and with many awards to her credits and a great mentor to all of us. So over to you, Dr. Vaishali ma'am, to start the panel and introduce the panelists.
Thank you, Diksha, for such a kind introduction. And this is going to be a very short panel discussion on clinical case scenarios on preterm labor. Since afternoon, we have listened to all the talks and everything has been covered, right? From the progesterone, Maxalt, steroids, tocolytics, and even hyperglycemia, everything has already been covered. So we are going to have a very brief panel discussion that how to apply it clinically when a particular patient presents to us. So I would like to do screen sharing. Yeah. Nirav, can I share my screen, please?
Yes, please go ahead. Is your PPT open in the background?
No, it's not. It's not.
Please open the PPT first, then come to the Zoom screen. Then I'll guide you further.
Yes, it's open.
Okay, now please come to the Zoom screen where you can see all of us. Are you on the Zoom screen?
Yeah.
Can you see all of us? The video of all of us?
No. Yeah.
Perfect. Now please click on the share screen button, the green share screen button at the bottom, and then a tab will open. In that, there will be some small sub tabs. Just choose Microsoft PowerPoint there. That is open in the background.
Right. Yeah. Got it. Thank you.
Sure.
So I'd like to invite our esteemed panelists for this panel discussion, and my apologies to all of you who've been waiting since so long for the panel discussion and then the subsequent panel which we are going to have on preterm IUGR. So this will be a very brief panel. I would like to welcome our panelists, respected Dr. Pawan Dheer, a very well-known successful gynecologist from Ahmedabad, Dr. Anju Soni, she's chairperson HIV committee. Welcome, ma'am. Dr. Varsha Baste, ma'am is again a co-chairperson, and Dr. Vidya Thobi, she's also chairperson, food and drugs. Dr. Samir Pradhan, he's a very busy endoscopic surgeon from Mumbai, and also my classmate, and Dr. Diksha. Diksha, are you there?
Yeah, ma'am.
Yeah, she is the Northern coordinator of my perinatology committee, FOXY, and so moving. Okay.
Click on the slide.
Yeah. So we've already been through definition. What is preterm labor? Since afternoon we are listening to it. Now this is the first case. Vidya ma'am, I would like to direct this to you. A 30-year-old primary gravida has come and she's been transferred at a tertiary care center at 29 weeks pregnancy. Pregnancy has been throughout uneventful, but right now she has two contractions every 10 minutes, and these contractions last for 15 seconds. So, Vidya ma'am, what do you think? What is your diagnosis? And do you think this is preterm labor? What is the criteria to diagnose preterm labor, and how will you evaluate the patient?
Having contractions minimum, if the patient is having contractions, 1 or 2 contractions per 10 minutes, and the contractions which are making changes in her cervical dilatation or effacement, we diagnose it as preterm labor. It can be a threatened preterm labor if there are contractions and there are no cervical changes, or actually there may be cervical changes, then we call it as a preterm labor. And if the dilatation is more than 3 centimeters or 4 centimeters, we call it as an established preterm labor. So in this, whenever the patient comes, very important is the history taking. So preterm labor is extremely common in extremes of ages, or patient if they have any medical disorders, or it might be a iatrogenic in case some of the cases of preeclampsia, we induce them preterm, or there are environmental factors like stress and physical exertion. These are the history taking very important points one should make. And the most important in the past history is the previous history of preterm labor. So that is very important. Any history of cerclage in the past, any history, second trimester abortions, and these are the points to be noted, and any history of infections. Infections in the present pregnancy, like a simple asymptomatic bacteriuria or any vaginal infections, that also can lead to, earlier we used to screen these women at 14 to 16 weeks. So the vaginal infections also can lead to the preterm labor. So there are various factors already the previous speakers have discussed in length. So there they have discussed about the genetic predispositions also. So these are the few factors always whenever the patient.
So you agree, ma'am, that history is very important. Now this is a primary gravida. Maybe for her it is not important, but whenever a multi comes, a past history of preterm labor or past history of mid-trimester loss is extremely important. It indicates that they could be this patient is at high risk. Initially, when she comes, you need to assess the patient, like how much is the contraction, dilatation, effacement, how much time do you have. Your entire management is going to depend on your initial evaluation. Whether you have time to give this patient steroids, or you need to put this patient on tocolytic, or if there's infection, you need to put on antibiotics. So initial evaluation and history taking is really very, very important. Anju ma'am, I would like to ask, and I can see Komal has also joined. She is also one of our panelists. Dr. Komal Chauhan, welcome. Dr. Anju ma'am, this for you. What are the risk factors? We know there are modifiable and non-modifiable. So if you can just enumerate.
Coming to the risk factors, we all know that ethnicity is number one. Caucasians are more prone to have this problem. Then age of the mother, extreme of ages is important. If the woman is less than 18 or 35, then the risk increases. Then certain lifestyle and environmental factors, including late or no health care. Then smoking, drinking alcohol, using illegal drugs, domestic violence, including physical, sexual, or emotional, and also lack of social sport and stress, long working hours, and exposure to environmental pollution, and then up, any kind of infection, say maybe urinary infections or sexually transmitted diseases. They also make it prone, like bacterial vaginosis and trichomoniasis. Then medical disorders like high blood pressure, diabetes, etc., and other medical disorders. Then bleeding for vagina, certain developmental anomalies of uterus. Then pregnancy from IVF, underweight or obese patients. Then short time between the pregnancies. Then placenta previa, or covering the os. Then again, another is rupture of uterus, could be because of previous surgeries, or maybe cesarean delivery. And then blood clotting problems. And also a woman who has delivered had a preterm delivery in earlier pregnancy. And also the most important, one of the most important is multiple pregnancies or hydramnios, where there is over distension of the uterus. And some women may have a congenital anomaly of maybe having the short cervix, or some other unicorner type of uterus. All these are very, very important conditions which we need to take a great history in detail, and then only we will be able to go. And when we were talking of medical disorders, as I said, hypertension, anemia, thyroid disorders, and SLE, and also asthma, etc. So these are the
Yeah, Anju
important
ma'am,
things
so
which we
beautifully you have, yeah, I don't think you have left any of the risk factors. You have enumerated all of them so wonderfully, and that is why we emphasize on prevention of preterm labor. It is better to counsel the patient, pre-conception counseling regarding all these
on
risk
the first
factors. Yes,
on
ma'am.
the first visit,
So,
it's very essential to do a detailed history. Even in first pregnancy, she may be having some kind of problem, so we have to take a detailed history. Even the past history and family history is very, very important.
yeah, absolutely. So you mentioned medical disorders. Let's move to the chairperson of medical disorders committee, Foxy. So Komal, can you just tell us about what are the strong predictors of preterm labor, and can you just tell us very quickly about role of ultrasound?
Thank you, Dr. Vaishali, and let me congratulate you for this fantastic, excellent conference. Very, very informative and very great orations. And coming back to preterm labor, we are all talking about awareness, and very beautifully the previous Dr. Vidya and Dr. Anju has said. But there are certain very strong predictors, as in there are clinical predictors. When the patient is giving a history of preterm birth, or patient is giving a history of symptoms of preterm birth in her previous pregnancy, if there is a multifetal pregnancy, infections like bacterial vaginosis or any candidial or any fungal infection, they would be a clinical predictors. Then there are biophysical predictors, like if patient is coming in active labor with inclined contractions, which are uh, more for more than 4 hours, or Bishop score, there is a significant Bishop score is more than 4, and shortening of the cervical length, that is less than 2.5 millimeters. So 25 millimeters, that may be your biophysical predictors. And there are many numerous biochemical predictors, actually so many enumerated, as all these interleukin and salivary histriol. But fetal fibronectin is somewhat which is seen to be little more better than the other all these biochemical markers. And what is more promising is that ultrasound assessment of the cervical length, and that is the most promising. And we need to assess the cervical length not for everybody, but those who are actually showing symptoms of preterm labor, or in where we feel that they are, we can predict that they are the ones who will land up into preterm labor. And on ultrasound, what we will, apart from seeing the cervical length, which we have already discussed, because when we know that the cervical length decreases, that if it decreases less than 3 centimeters, then the chances of preterm labor is really very high in this patient. So almost 80% of the patient may land up, 82% will have some symptoms of the preterm labor if the cervical length becomes less than 3 centimeters. And if it is really less, maybe less than 2.5 centimeters, then the chances will increase. So we all know the predictor that cervical length is important. Apart from that, funneling of the cervix is also a very important parameter. And sometimes if there is a short cervix and funneling, then the studies have shown that definitely this patient is short going to land up into preterm labor, and that also within the stipulated time, within 4 weeks of diagnosis, the patient is bound to deliver. So we can actually deliver her date of delivery. Apart from the cervical length, what we would see on our ultrasound is definitely the how is the fetus, the cardiac rate, if there is a multiple presentation, what is the presentation of the fetus, if there is any multiple gestation, the weight, because the baby is going to deliver preterm, but what is the baby weight, then the placental position, if there is any evidence of IUGR, how is the liquor is adequate or no, is there a polyhydramnios, also the Bishop's score, biophysical profile also can be known on the ultrasound. So all these parameters of fetal well-being can be really well appreciated on an ultrasound. And ultrasound is like a tool in our hand where we should use, and in preterm labor, it is really going to tell us a lot more.
Well said, Komal. So when we talk about strong predictors of preterm labor, there are only 3 which are very important. That is presence of fetal fibronectin, which unfortunately we are not doing. It is the glycoprotein which is present between the decidua and the chorionic membrane, and its presence beyond 22 weeks of pregnancy indicates that labor is the delivery is imminent. So it is out since we are not doing it regularly. So 2 important factors are there for prediction, that is the mid trimester short cervical length less than 2.5 centimeter and past history of preterm labor. So these 2 strong factors are very strong predictors of preterm labor. And like Dr. Komal said, cervical ultrasound for assessment of cervical length is important, and we'll be having a next panel in that they'll be speaking more about the ultrasound and imaging. But it is essential to do mid trimester cervical length assessment from 16 to 24 weeks of pregnancy. And for high risk patients, you can do as early as 14 weeks of pregnancy. So now we have this patient who has had a past history of preterm labor, and in this particular pregnancy, the cervical length is 1.5 centimeter at 20 weeks of pregnancy, 1.5 centimeters. So coming to Dr. Samir Pradhan.
Yeah,
Samir
thank
is
you.
an endoscopic surgeon. So
I'm also
Samir, I would
obstetrician.
like
I am
to
also obstetrician, Vaishali. And thank you so much for this
your
opportunity.
question.
Yeah. So now, what you have mentioned is the role of prophylactic and emergency circulage. When we also call it very loosely prophylactic circulage, but it is actually a therapeutic circulage. We have had a nice debate on circulage, and this case which you have mentioned specifically, past history of preterm labor and 1.5 centimeter cervical length on an anomaly scan. This definitely is for me, it's an indication for circulage. At this point of time, I would like to tell all those delegates that when you want to do a circulage, always do a Shirodkar circulage with a Mercilin tape. We have always been doing McDonald's circulage, and I, in my private practice for last 20 years, I have done a lot of failed in the previous pregnancy. McDonald's circulage have been treated successfully with Shirodkar circulage. I personally feel the advantage is the Shirodkar circulage gives, it's more anatomical. It is at a higher level. It just requires a slight dissection, like we all do for a anterior colporrhaphy. It helps in addressing the point at the main level. and also it changes the polarity of the uterus and also prevent the loss of the mucus plug. Additionally,
Which circlage do you do,
I
Sameer,
do
in
always
your
Shirod curse
always
circlage
Shirod curse?
with Marceline tape. I used initially Mersilk and Ethilon, but then when we remember, we used to see the advantage of Merceline tape. We used to learn for the exams, so I started shifting to Merceline tape because there was one MOGS webinar where Dr. Asharit Singhani had come, and at their place they say circlage is outdated because it causes a lot of infection. She showed ultrasound photos of liquor showing all this haziness. So then when you have a Merceline tape and you cover the anterior part with a vagina, the part of foreign body iatrogenic infection is much less. So I always do a Shirod curse circlage. Then there's another place called emergency circlage, which is also called rescue circlage. Sometimes on a sonography, you may see the os open and the membranes lying in the cavity. In such cases, if there is no preterm labor pains, no evidence of chorioamnitis, and no evidence of antepartum hemorrhage, only in such cases a rescue circlage can be useful. And one has to use certain techniques for that. One has to give a partly full bladder. One has to take a Foley's catheter, fill the balloon, cut the tip, which is the and then that Foley's bulb can be used to reposit the membranes. And here Shirod curse may be a bit difficult because handling of the cervix will be much more. So here one can, but still use Merceline tape and do a McDonald's circlage. I personally have never done a laparoscopic
circlage.
So I personally don't like. I had a lot of arguments even in laparoscopic conferences with the people who propagate laparoscopic circlage. I had never seen a Benson and Duffy even in my career as an abdominal circlage. So I personally feel it is laparoscopy. People are going overboard and they are recommending it in between the two pregnancies. So I personally feel a circlage should never be done between two pregnancies because there can be first trimester losses. So at the most, the earliest I have done a circlage is after the anomaly scan and a dual marker test. Those who have had early trimester. So at that time, it is very difficult to do a laparoscopic circlage. People have been doing it. I don't know why. But now a lot of my friends who are laparoscopic surgeons who have called me during an emergency in a pregnancy and then said, how do we go about Shirod curse circlage? So Shirod curse circlage can be repeated by everybody. Everybody can practice it. And I don't recommend
So the message here is if circlage is required, do it to the best of your ability. If you are used to doing a McDonald's, please go ahead and do a McDonald's circlage. If you are skilled at doing Shirod curse, because in Shirod curse, you need to dissect the bladder. Then you can do a Shirod curse. The main aim is to go as high as possible and at the level of internal os. That is where we aim to put the stitch. And how do you identify? It's because of the smooth cervix and the rugosity of the vagina.
Yeah.
Between that junction is how you identify. Yes, Anju ma'am, you want to say something?
I say that we are all vaginal surgeons and we are all very good with any kind of vaginal surgery. And I
right, you're right. And like Dr. Sameer said,
actually, what I wanted to stress here, I want to stress here is everybody of us who have passed have done a vaginal hysterectomy where we have dissected the anterior cervical wall. For me also, even I had done only one Shirod curse circlage till I passed my MD, but now I shifted completely, and trust me, it is not difficult at all. So everybody should take home this message.
Method has its advantage and disadvantage, and this is definitely not a debate. The take-home message here is when it is indicated this patient has past history of preterm labor, now the cervix is short, and yes, this is an ideal patient for os tightening. And in case she refuses, it's not necessary to do circlage. You can put the patient on progesterone also. We'll discuss about that later. So regarding rescue circlage, like Dr. Sameer mentioned, there are certain contraindications. If there are active uterine contraction, do not go in for rescue circlage. If there's infection, bleeding, do not go in. And if the cervical dilatation is more than 4 centimeters, then rescue circlage should not be done.
If there is already an effacement has occurred, it is likely to fail.
Yeah. So now coming to our next question. This is for Dr. Pawandir. Sir, can you just elaborate about progesterone and its role in prevention of preterm labor? Alternative to circlage for this kind of patient which we were discussing. Can you use it instead of cerclage?
Yes, progesterone is basically a uterine quiescent, and it acts at four sides of uterus. It acts at placenta, it acts at amniotic fluid, it acts at fetal membrane, myometrium, and cervix. And basically, it suppresses the calcium, calmodulin, myosin light chain reaction, which is suppressed at all the levels, and basically it prolongs the pregnancy. We have been using progesterone in high risk pregnancies, and it is very effective. And very recent study shows that it is as good as cervical and cerclage. We use it also after cervical and cerclage. It is very effective drug. There are two types of progesterone. One is natural micronized, and another is hydroxyprogesterone. The disadvantages of uh, hydroxy is that it cannot be used when the cervix is short, and many times it gives rise to the potential diabetes in high risk cases. This is only to be used as intramuscular weekly basis, and it is not effective when the cervix is short, where the oral or micronized vaginal progesterone can be used, which is very natural, which can prevent the cervical ripening, and it is very effective even when the cervix is less than 15 or 20 millimeters.
Yeah, so rightly said, sir. And progesterone means pregnancy. It causes quiescence of the uterus and it maintains the pregnancy. And progesterone can be various types. It can be a sustained release formula. It can be a vaginal gel. It can be a vaginal tablet. It can be injectable. So whatever you are comfortable with and you're used to prescribing, you can. There's lot of evidence here which says, these are Western Australian guidelines 2007, which which says, cervical length here they have taken as less than 10 mm, and in this you can use vaginal progesterone. There's a European Association of Perinatal Medicine, 2017. Ma'am, just I'll come back to you. French clinical guidelines, NICE guidelines, STRAT OG, ACOG, SOGC. They all have emphasized that yes, you can continue using progesterone instead of cervical cerclage or as along with cervical cerclage. You can do the cervical cerclage and then put the patient on progesterone. Ma'am, you want to add something to progesterone?
Yeah, I just wanted to add, Dr. Jaideep Tank has presented a very beautiful, presentation where
Yeah, we heard.
the importance of vaginal absorption. Vis-a-vis intramuscular was very good, and he said oral should not be given as compared. The absorption
Yeah,
is
so there are different thoughts and there are a lot of multiple studies. Like I said, there are so many preparations you can use. Now, when you use vaginal progesterone, our Indian population, there have been Indian studies which have shown the
Yes.
Indian population, Indian women are a little reluctant for the vaginal messiness of the gel and the tablet, and oral microgenized progesterone gives equal results. So there are multiple controversial studies.
When the oral, what Jaideep has said, and oral has to be used, it is better to use dydrogesterone.
Yeah.
And what you said is very right. Our Indian people are very reluctant to use vaginal tablets.
Yes,
And even in
and again about dydrogesterone, what Dr. Jaideep has said is absolutely correct. But
there are
more
no
role
studies.
in RPL and
Yeah,
earlier pregnancies and repeated pregnancy loss
Right,
rather than in preterm labor.
Right.
So I think all the panelists agree about progesterone. So moving on to Dr. Diksha.
And Dr. Vaishali, just we are using these days progesterone with IM proluton also in IVF cases with very good results.
That's right. That's right. So we move on to Dr. Diksha. This question is for you. As obstetrician, we deliver the preterm baby and we hand over to the neonatologist. Baby goes to NICU. After a certain time, we lose contact with the mother once she's discharged from us. And then that baby stays for a long time in the NICU and goes through such a sequelae. And it is really a huge burden on the family, emotional and economical in every way. So, can you just tell us shortly about long-term sequelae for these preterm babies?
Yeah, thank you, ma'am, for this question. We did have an extensive talk on the same, so I would like to keep it short. Preterm babies are a major cause for neonatal mortality and morbidity. So these are the babies which we lose more often. And survival of these babies usually will depend on the gestational age at which we deliver them. The most common complications in these cases are mostly respiratory because of the alveolar immaturity and the absence of surfactant. So these babies can have respiratory distress syndrome, hyaline membrane diseases, hyaline membrane disease, and because of that, they can also have pneumothorax. There's need for intubation, need for ventilation, NICU admissions, prolonged hospital stay. They're also prone for hypothermia, feeding problems. And if they're extremely premature, then they also have risk of bronchopulmonary dysplasia. Apart from the respiratory, the other important morbidity in these preemies are the intracranial hemorrhage, which can be intraventricular hemorrhages or primary subarachnoid hemorrhages or intercerebral hemorrhages, which also make them prone later on for hydrocephalus and long-term sequelae. These babies can have cerebral palsy. Apart from that, because of the liver immaturity, they can have neonatal hyperbilirubinemia and jaundice. In cardiovascular, because of PDA, they can also end up having congestive heart failure. And when we talk about the long-term sequelae, because of the hypoxia due to the respiratory problems and prolonged oxygenation, they can have retinopathy of prematurity, or even as an adult have chronic lung diseases, asthma, alveolitis, because of and cerebral palsy, developmental delays, learning disability. So yes, there's a lot of challenges associated with them, and even as an adult, these babies can have increased risk of developing hypertension, diabetes when they grow up.
Yeah, you have, I think, enumerated everything, Diksha, and that is the reason we are working together with the neonatologist and the pediatrician, and it should be a teamwork. So, continuing with the
Sorry
same
to
case,
interrupt, Dr. Vaishali. 5 minutes left.
uh,
Thank you.
yeah. So now this patient, the cervix is dilated. It's 2 centimeter. There are contraction. Uh, Now this patient, do you think requires tocolysis? And what is your agent of choice? I want all the 6 panelists to tell me the tocolytic agent which they would like to use, starting with you, Vidya ma'am, and then with everyone.
Yeah. Thank you, Vaishali. Tocolytics play a major role, and this major role is we want to have the safe in utero transport to a better facility, and to act for the action of the antenatal corticosteroid. These are the two aims mainly, and we never prolong this tocolysis more than 48 hours or more than 7 hours. Now, the choice of tocolytics is there are specifically developed the utero specific, and my choice is always nifedipine, though it is not licensed in India, but it is very, very easily available, and we can easily administer and with less side effects. My dosage is usually 20 to 30 milligram loading dose orally. 30 minutes again I give, and never I give a sublingual, and usually oral, and it is contraindicated in cardiac, renal diseases, or whenever the patient is having maternal hypotension. And always don't use with magnesium sulfate. When you are using magnesium sulfate as a neuroprotection, never ever use nifedipine. So you should also know about the side
Your
effects.
choice
So
is
yeah,
nifedipine. Yeah, Anju
nifedipine.
ma'am, what tocolytic do you use?
My first choice would be etisoban, but it sometimes is very expensive. If you want to give in a
And
dose.
what is your second choice?
So most of the cases, they come to Doodlon, or what we call it, isosuprene.
Isosuprene would be your choice.
We have been
5
using it
minutes.
for ages. I think almost from the time we are doing our post graduation for more than 35 years, we seeing it, and it gives us a very good result and very few side effects if given properly in a proper dose, and it can be easily shifted from intravenous in the beginning to the oral, we have seen, all of us have seen that it can prolong the pregnancy to more than 7 to 10 days, and sometimes longer. So I feel beta agonists, as
Beta adrenergic agonist, so
they
is
are
what Anju ma'am
they
says.
are equally good, and the cost factor and all these things still favor them, and we have over the years not found any much of problems. So wherever possible, where patient can't afford, I prefer to give this along with magnesium sulfate for neuroprotection, because definitely magnesium sulfate is very very effective for neuroprotection. And with the precautions, definitely time is short, I will not go into detail.
Yeah.
Along with this, I would prefer to give a dose of betamethasone, that means corticosteroid.
We'll come to that later on, ma'am. We are talking about tocolytic. So,
Yeah, yeah.
Anju ma'am has very strongly spoken for isosupreme, that earlier, since many years, Indian gynecologists have that opinion. In between, they said don't use it because there's pulmonary edema and all those complications. But again,
Now
now
it has
it is
come
back. Now it has come back, and there's a lot of evidence and studies which have been done. And even TOG6 has, Foxy has released. In that also, they have written for isosupreme that yes, you can with good patient selection and monitoring, of course. Anybody else wants to
Yeah,
add which
I would
tocolytic?
add the isosupreme
I
is something which
used
we have been using it, and what we see, the patient is in proper preterm labor, and she requires an immediate care. We can give them the isosupreme to begin with, and then our progesterones also can act. You can give that much time. I think for 3 days or for you giving isosupreme, continuing the IV, then tapering the dose also, which we have seen in practice where we have used it in some patients, because earlier we have used it left, right, center, but now nifedipine has taken over because there are certain indications which
So
in
you would
nifedipine,
go with isosupreme and
not
nifedipine.
as a first
Samir,
choice
what
for
about you?
nifedipine, but
I
definitely
will
Yeah.
agree to what Dr.
contract.
Anju Soni has said. When
Yeah.
you made us, we wrote the chapter for your book.
Yes,
Uh,
book, and
we
that
had
got released
found
today
all
as
the
newsletter.
references. All
Yeah.
the references were against the beta mimetics, but then practically we were still using it. Atosiban is the first choice, and they say even the first two doses, the immediate 1 minute dose and the 3 hour dose is also enough. Or if no one does not have a cost constraint, but I have not used till date. I don't use nifedipine because it is not labeled to use, and I want to give Maxel for the neuroprotection. And there is this controversy that nifedipine and Maxel cannot be used together, so I don't want that risk. So I still prefer isoxsuprine. I used to use a lot of terbutaline, Bricanyl, but it is not available.
Yeah.
But one of my friends used syrup Bricanyl is still available. So some people, it's there for the babies. So that also calculated adult dose can be given as an
Yeah, but
alternative.
it is not
Dr. Vash,
affordable, na?
Yeah.
Many atosiban is
Syrup
not
Bricanyl is
affordable.
available, madam. Injection is not available, but it is one of the best.
So beta adrenergic is what Samir is saying. Pawan sir, you wanted to say
sir,
something.
I use isox in 75% cases. I have used atosiban in IVF cases, 7 cases, because I believe in those 48 hours which are best with atosiban, though it is safer, costlier, costing nearly 40,000 rupees to the patient. But these 48 hours are very important. There are less chances of RDS, though for my mediocre patients, I still use isox.
Yeah. Diksha, you want to add anything?
Yeah, only thing, ma'am, like for me, I think the first choice would be nifedipine because I feel there's lesser monitoring involved and it's safer
Yes,
and
easily available.
less restrictive in its indications. And second choice would be beta mimetics. And atosiban a little bit hampered only because of the cost issue.
Right, right. So the message here is there is no right or no wrong tocolytic. Whatever you're using is the right
Individualized.
tocolytic. Isosuprine was, earlier everybody used to use. In between, they said don't use. Now again it is back, and there is a lot of evidence going for it. There's this particular study which was done, multicentric retrospective study, comparative, and I was also one of the PIs doing it, and which shows that isosupreme, there's prolongation of delivery beyond 48 hours, and perinatal outcomes were much better. So whichever tocolytic you choose, there have been so many. Even indomethacin you can use till 32 weeks of pregnancy. And even nitrous oxide donors, NTG patches, you can use terbutaline, like Samir has said, and of course atosiban, but that is little expensive, and there's a specific way of using it. So all of you agree, and you have told about the steroids. Now, coming about Anju, ma'am, you were talking about steroids. So when should it be administered? What is the drug of choice? Which steroid?
If a actually, we have been preferring to give betamethasone as compared to dexamethasone. But cost factor again, dexamethasone is cheaper as compared to betamethasone. Otherwise, betamethasone is preferred because it is less extensively metabolized by placental enzymes, and efficacy and one dose is more than enough in most of the cases, except if the delivery doesn't occur within a week, you can repeat a dose, but only the second dose, but one dose is more than enough, and it is given at the dose of 12 milligram in 24 hours. And dexamethasone, if you want to give, you can give 6 milligram 12 hours apart, 4 doses. These are the doses to be given. And in high risk cases where we expect that the patient may go into preterm labor, in those cases, we can give betamethasone or corticosteroid for prevention of there is no harm, and it gives much benefit as precautionary measure also we are giving.
Like
Wherever there
ma'am
is
said,
a
you can use betamethasone, dexamethasone. Does anybody want to differ about this? I think it's
What
a
Vaishali, the
universal
literature
agreement.
says for RDS prevention, betamethasone is better, but for intraventricular hemorrhage, dexa is better according to the pediatric people. And earlier we used to give every weekly doses, but that is now given up. But one can still give a
Absolutely
rescue.
out.
One can give a rescue dose. Suppose more than 7 days are over after the first loading dose, which is 24 hours apart for betamethasone or 12 hours apart for dexa, and then the delivery is imminent, then one can give a rescue dose and wait for another 12 hours if possible.
Vaishali, I just want to add one thing. I
Yes,
want to
please,
add the betamethasone salt which is available in India.
Yes.
It is not a very effective one, and the National Health Mission is always it advocates DEXA.
Yes.
So DEXA is cheaper, it is available, and it is effective. So DEXA
Since
is preferred.
since 2 years, I just left betamethasone because
Yes.
salt is not available, and I am using DEXA, except in few cases of diabetes where it adds to the sugar.
So, will you not give steroid in a diabetic patient when it is indicated?
No, we have to, but we have to tell the patient that the insulin requirement may be more. So it's better to admit such patients, because if one observes that transient increase in the glucose levels after any steroid, either betamethasone or dexamethasone, can sometimes the patient can complain of decreased fetal movements, which can be very alarming.
Yes.
So that is one caution, and that high levels can remain high for almost 1 week.
Yes.
Yeah. So the message here is, please give steroids even if you have very less time, few hours for the patient is going to still give steroids, because it's going to help the babies reduce the respiratory distress syndrome. Suppose there's no dexa or betamethasone, if there's hydrocortisone, give that, but please give steroids, and your neonatal colleagues will emphasize about it.
And one more thing
And,
is, in diabetic babies, the fetal lung maturity is still prolonged. So, though traditionally they say up to 34 weeks, if the diabetic, one may extend it to up to 36 weeks also.
36 weeks also.
Yeah.
My anesthetist says that give something, beta or dexa, but it will prevent postoperative vomiting also.
So, since we are very, very short of time, actually, this kind of discussion, when we do a panel discussion on preterm labor, it never ends. It's an ongoing thing, goes on for 1.5 hours, but I'm very short of time. This is the last question I'm going to take about Maxself. And after this, we are going to wind up because we have one more panel discussion waiting. The second case we are not going to take. So this is the last question regarding MaxSelf. Any one of you can take it. What are the indications and the dose would you give MaxSelf?
MaxSelf is for neuroprotection now. By so many studies we have, and a lot of evidence also. Even the MACPE trial which was done, they have also proven that magnesium sulfate is a very good agent for neuroprotection. As Diksha has very well said, that when we are talking about an preterm baby, we are worried about the cerebral palsy, the motor functions in the longer run. So giving magnesium sulfate for neuroprotection when gestational age is 24 to 32 weeks, and we feel that the delivery is imminent, and the dose is also very simple, that we need to start the dose of 4 gram IV bolus for 20 minutes, and then the maintenance dose of 1 gram per hour for 24 hours or until birth, whichever occurs first. And the monitoring is also the same way as we monitor whenever we give magnesium sulfate to any patient, that is the respiratory rate, patellar reflex, urine output should be adequate, around 30 cc's per hour. So this is the way we monitor, and we need to give magnesium sulfate, and it has so many studies and have shown benefit, and we have already been using about it. So I think there is no debate, and I think all the colleagues in the panel would be agreeing.
Only thing is it should not be not required for neuroprotection beyond 32 weeks. It's only up to 32 weeks.
24 to 32 weeks only.
And the second thing is it should not be more than 24 hours for neuroprotection. Like for eclampsia, it is till delivery, but it is only up to 24 hours or lesser.
Never use
so I think
Maxalfate,
everybody.
Nifedipine, never use it.
So I think
and one should
all
always
our
have
panelists-
calcium gluconate in your armamentarium when you are using MaxSelf.
So that time we have a restriction.
We are proficient in using MaxSelf as obstetrician. We all know MaxSelf, and all the expert colleagues, expert panelists, I think agree on all of these things. So in a very short time, we have covered the case completely, right from history and ultrasound and evaluation, steroids, tocolytics, MaxSelf, everything. So I would like to thank each of my expert panelists, and thank you very much. And it was an honor and a pleasure.
Thank you, Vaishali, for a very well conducted panel and an excellent program. Thank you and congratulations.
Thank you very much. Thank you all of you. Thank you all of you.
Congratulations.
Thank you, Dr.
So I
Vaishali.
hand over to Priyankur now.
And belated happy birthday.
Yeah, thank you. Thank you. Yeah, Priyankur, I hand over to you.
Yeah, thank you, Vaishali ma'am, for really summing up and proceeding with the panel, as we were running a little bit short on schedule. And now we move on to our next interesting panel, born too small and born too early. And for this, I invite... born too small, born too early, and we'll be addressing the management dilemmas in preterm IUGR. And our expert for this session is Dr. Archana Basir, ma'am. Ma'am, I welcome you as an expert for this panel. Ma'am has been the chairperson of FOXI Imaging Science Committee. She's a vice president FOXI. She's been the organizing secretary of ISAR and managing committee member of ISAR. So welcome, Archana Basir, ma'am. Ma'am is there? Okay. I move on to welcome the moderators for the next panel discussion. Our first moderator is Dr. Meenu Agarwal, ma'am. Ma'am is a National Director, Clinical Board, Morpheus IVF. She's an Executive Board Member, International Society of Gynecological Endoscopy. She's a chairperson, dynamic chairperson, I must say, of the Imaging Science Committee, a very active person in all conferences and a great orator. Our next moderator for this panel is Dr. Chinmay Rata, and ma'am is our incoming chairperson for Perinatology Committee.
We'll move on.
Resolution Fetal Medicine Center, and a senior consultant, Yashoda Hospital, Secunderabad. So welcome, ma'am.
Thank you.
And we can please proceed with the panel.
Thank you so much.
My video is not getting on. Can you do? Is it switched off from your end?
Meenu, ma'am.
Yeah, my video is not getting on. Is it?
Meera, can you see?
Yeah, just a minute.
Sure.
We need to see Meenu.
Yeah. You can start in the meantime. Chinmay, you can start.
Okay, ma'am. Thank you. And a really late good evening to all of you who have been patiently waiting for us. We were all thinking that we'll have very little audience, but Priyanko tells me that a lot of you are still waiting, and that's the spirit of perinatology. So how small is too small and how soon is too soon? We have come very late, but we are going to address all the questions. And I have this very eminent panelist, expert panelist today, Dr. Varsha Baste, who is the chairperson of the International Academic Exchange Committee of FOGSI, Dr. Shobha Gori, chairperson of the Family Welfare Committee, Dr. Sneha Bhuya, chairperson of the Breast Education Committee, Dr. Bela Bhatt, incoming chairperson of the Imaging Science Committee, Dr. Gauri Karandikar, a very, I mean, I've interacted with her so much now, that extremely spirited and dynamic obstetrician from Nasik, Dr. Niharika Malhotra, chairperson of the Young Talent Promotion Committee of FOGSI. So Dr. Stehab from yeah. So can we see Dr. Meenu? She's been the guiding force of this panel, and my co-moderator, somebody whom I've ardently followed in the Imaging Science Committee. Where is she, ma'am? Unfortunately, your image is not coming up onto the screen.
Right. So
But
what I will do is, Nirav, I will log out and log in again. Sometimes that helps.
Yeah.
Okay, so you can start with the first case. I welcome all the panelists over here. Chinmay, you can start with the first case. I will log out and log in again. Maybe that will.
Sure, ma'am. So we'll just.
Yeah, doctor, actually, you need to connect your camera. Your camera is not connected.
Okay, I will log out and log in again and connect the camera. I'll do that.
Sure.
Okay, so we'll just wait for Meenu ma'am to join us. And in the meantime, let me just set the stage that the topic of this discussion is born too small and too early. We just heard about too early. Preterm labor was just addressed. But when the baby is very small, and that is the reason of being born early, we have some management dilemmas. So preterm IUGR is the topic of this panel. We all know by now that it's a preventable morbidity and mortality scenario where early diagnosis, monitoring and delivery, appropriate timing for the delivery and monitoring would make the difference between a good and a bad outcome. So we know that prematurity itself is a very huge cause of healthcare burden. So there is a burden on the resources, and it all translates into a lot of pressure on the families, on the society in general, and hence to reduce the burden of prematurity, and that too by way of optimizing outcomes of IUGR, is what is the challenge that this panel has today. So the first, yes.
Sorry to interrupt. Just to keep the morale of all the panelists high, because I'm really sorry for us getting so late. We have around 1020 attendees with us right now. I think that's a very good number right now.
Perfect.
So just for
I think hats off to all those 1,000 people. That's very kind of everybody to be here. And indeed, the panelists have worked so hard for this that I think we should be heard. So
we can see Meenu now. We could see Meenu now. Yeah, there she is.
Okay, wonderful. So the first case we have is a primary gravida at 28 weeks gestational age. Medical and surgical history was not significant here. She had normal antenatal checkups in the first trimester, low risk for screening for aneuploidies, normal TIFA scan, and at 28 weeks, routine growth scan. She came just for a routine growth scan, and what we found was growth is on the 3rd centile. There is increased resistance in the umbilical artery Doppler. Now, this looks like an IUGR. Varsha ma'am, we start the ball rolling from your side. What are the important points here that you would think before you confirm IUGR? The scan report says IUGR. What do you want to say?
First and foremost thing is dating, confirmation of the dating. So absolutely. Dating is very important. The serial follow biometry with the serial USG, how much is the biometry falling, or there is no correlation with the normal growth of the fetus, and abnormal Doppler. See, uterine artery, umbilical artery, or ductus venosus, or mid more than 95th centile, or MCA or PCR, CPR less than 5 centile is very grave, and it indicates when to stop or when to start, when to take the patient for delivery, and it will tell us the prognosis.
So we'll go step by step, ma'am. So
are very important.
your first thoughts are that whether the dating is correct or not. That's one of the most important things to remember, that whenever we see IUGR, we have to check the dating. So early pregnancy scans are the best for dating. And then once the dating has been assessed, look at the serial biometry, because I told you that till TIFA scan, everything was normal. So obviously till that time, the biometry was normal. Now, when you compare, there is a slowing of the growth, and then there is some abnormal Doppler that has been stated there. So it looks like an IUGR. Sneha ma'am, now there is IUGR. Would you call it early onset IUGR, and how are you going to plan management?
Yes, definitely. According to the international Delphi consensus, we have the category as early onset, that is before 32 weeks, and late onset, that is after 32.
Is it important? Is it important for you to classify it as early and late?
The management as well as the prognosis both differ, and that's the reason we are supposed to first categorize them. If the gestational age of less than 32 weeks in the absence of congenital anomalies, what all parameters you should correlate: the abdominal circumference, estimated fetal weight ratio if it falls below 3rd centile, and the AC and estimated fetal weight is below 10th centile, along with the uterine artery pulsatility index of more than 95th percentile, and the umbilical artery pulsatility index of more than 95th centile.
So you agree that there is a difference between early onset and late onset, and what would you think is what strikes you as the difference between early onset and late onset? Because in early onset, you have more challenges. It's a very, very early gestational age.
Yes, definitely. To taking this pregnancy till maturity and the salvageable fetus, it's a long way to go, and that's the reason the monitoring of both the mother as well as fetus both are important. We have to monitor the maternal condition as well as simultaneously the fetal growth as well as well-being. And that's the reason.
Here, basically, diagnosis was not such an issue for you, because as soon as she came, you could diagnose this is IUGR. But now managing it is a challenge because she's only 28 weeks. And that other entity, late onset IUGR, managing it might not be a problem because the gestation age is advanced, but diagnosing it might be a challenge, which we will see later on. So moving on.
There is the important thing is the villus invasion or tropoplastic invasion is less in early IUGR, and in late IUGR the maturity of villus is
Villi is less. So there's a difference at the pathophysiology level. There's a difference at the presentation level. Absolutely. So now, Dr. Bela, we now know that there is IUGR, there is high resistance in umbilical artery. We were told in the previous panel, we are going to talk a lot about imaging here. Now you tell me, how do you plan to do further scans, and what is the Doppler? What are the changes you expect in progression?
Yes. So we know that this is 28 weeks with early onset fetal growth restriction. So further monitoring will be with the aim of prolonging the pregnancy as close to the term as possible, especially beyond 34 weeks of pregnancy, because we know that every day counts for preterm baby. Every day prolongation of pregnancy will improve the neonatal outcome by 1 to 2%, especially till 34 weeks of pregnancy. So we would like to prolong the pregnancy beyond 34 weeks, at the same time not increasing the risk of fetal acidosis and stillbirth. So that is our aim. So after giving steroids, I would like to repeat the Doppler after a week, and in which I'll be keeping an eye on umbilical artery PI, umbilical artery diastolic flow, and ductus venosus flow, as well as cerebroplacental ratio. But the cerebroplacental ratio is going to tell us whether the baby has cardiovascular adaptation or not, whereas our umbilical artery PI, diastolic flow, and ductus venosus flow will help us decide how long we can prolong the pregnancy. So based on the findings,
you want to wait until the ductus venosus flow abnormalities, because it is really a very, very early onset IUGR, and you want to take it longer, and you expect the baby to be with you till all this happens. Now, this is all very good. Technically, we have diagnosed IUGR, we have done Dopplers, everything, but now the obstetrician has this headache of explaining this to the patients and managing the thing. So, Shobha ma'am, the patient comes to you, and now you have to discuss this entire issue with her. What are the issues you don't want to forget while discussing everything with her? Shobha ma'am?
You need to unmute, Shobha.
Yeah, now I'm audible?
Yes, yes, ma'am.
Yeah. So one aspect of FGR which has not been discussed and traditionally always spoken of
all our audience will be familiar with it, is the concept of symmetrical and asymmetrical, which, we tend to give it a backseat today because it doesn't feature much. But it's important just to keep in mind whether it is symmetrical or asymmetrical, because we should not forget early onset IUGR, just ruling out gross congenital anomalies is not enough.
No,
must
we
also think in
actually
terms
addressed
of,
that. Sorry, ma'am, we've actually addressed that because this is without congenital anomalies.
Yes, I know, but there
classification-
are still some genetic problems which will not manifest as congenital malformations.
Sure.
We should keep that in the back of our mind, because this particular woman has no other maternal high risk factor for placental insufficiency. That's the only thing I wanted to point out. It should form part of our counseling. So we should not forget about the background maternal high risk factors. We should also not forget about where to deliver this woman eventually, because now that we have picked up a problem, we must look at their affordability for an NICU care as well, and look at whether we should deliver at our unit or send them to a place in utero transfer to a place where better facilities are available. Well, NICU counseling and consultation with the neonatologist should start early for this, but I do not agree with the plan of giving steroids now, because it is very early days.
We'll discuss that.
But
But
we have to wait.
you've now explained to the patient that the baby is not growing very well.
Yes.
There could be many reasons. Most commonly, it could be placental insufficiency, but because we can't rule out other issues, those are also
We
in the
have to
background.
keep an open. The book should be still open as to why there is IUTR.
That's very wise.
Then the family will be with us. They will understand what we are trying to do,
If at
and they
all,
will not expect the world out of this pregnancy. They will also know that there is some factor which is very
Realistic
early in nature.
expectations.
Yes,
Sure.
and as Sneha correctly pointed out, we are very remote from term. So they have to expect that. And as Bela correctly said, each day gained will be, preventing one more week of an ICU care,
NICU stay.
something like that. So they have to know all that, those factors.
So you want to involve the neonatologist right now, and in case
Fairly
you are
early, fairly
you-
early. When we
you're-
think that we'll not go beyond a few weeks, it's better to keep them in the picture.
No,
so
that's
that
an
they are
important
on-
thing,
I would
ma'am.
like to add steroids at this level.
No, we'll just come to steroids, ma'am, because we're going step by step. Let's get this message through. We'll come to those points. The message here is we've diagnosed it correctly. Then we involve all the stakeholders and explain the scenario. Even if you're going to do in utero transfer, even if your neonatologist is not going to handle it, it may be useful to get him to talk to the parents, because
Yes.
ultimately they're going to come back there only.
Yeah,
So
we believe that.
So-
Absolutely.
No,
The
they
reason
should.
I'm cautioning obstetricians is
Counseling
once the
by
baby is
people.
born, once the
Counseling
baby
by
is
two
born,
appropriate people is the best way, in fact, to
Yes.
counsel the parents.
yeah. So once the baby is born, the a mother and the family should not keep coming back to us for questioning. They should actually contact them first. I mean, they should speak to the NICU care holders first.
Ma'am,
and then
one point regarding the counseling that I would like to add is one thing. Can I, Chinmay ma'am?
Yeah, go ahead.
Yeah, one thing that I would like to add is that they have to be counseled, that the course might not be absolutely like what we have put in a big book picture. There are a lot of variations that can occur, and there are a lot of uncertainties that they should expect throughout the course. Also, they should also know that at 28 weeks, and any complication related to mortality and also neurological outcomes later, they also should be discussed with them right away, because when they are preparing for an ICU and the cost of therapy, like the Professor Nicholas always says that avoiding an NICU admission is a big cost that we are avoiding. So that is something which we need to counsel them really well regarding the outcome of the baby that we are going to look at.
I think all of us are on the same page there. And for the audience, exactly what it means is you tell them the whole story. You tell them you don't know how it's going to go. There is a lot of variability that can be there in the outcome. Be prepared for the worst. Be prepared to go to another place and be realistic in your expectations. And that's very important, because that's where all of us should stand when it comes to growth restriction, because we really don't know what's going to be the outcome. Now, coming to steroids, what happened was we saw her and Dr. Bela told us we are going to follow up with Dopplers. So we did the Doppler. It was only increased resistance, but there was growth restriction. So we called her back after 1 week to check the Dopplers again. And at this time, the Dopplers showed absent end-diastolic flow. Some of you said that we'll give the steroids at that point. If we had given the steroids at that point, we've crossed 1 week now. Now, suppose we had not given the steroid at that point, because again, we'll come to that. The decision to give steroids has to be taken very judiciously. Now, can we give steroids?
Yes.
Now everybody wants to give steroids because
Yes,
it is
yes.
absent in diastolic flow, and we are
Yes.
reaching a point where probably we are thinking about delivery within the next 1 week. So,
Chinmay, just a minute. Can you go back to the previous slide? Yeah, because which steroid is given has been amply discussed. I wanted a little more time on this truffle study because I think this you are going to relate to this more and more because it is supposed to give us the timing of delivery, and Bela should come in with telling us about the venous Dopplers, how they become abnormal, and you should tell us. Now, I just wanted to say here that are you going to discuss the venous Doppler in the coming slides?
no, you can go ahead. Let's
Yeah.
finish the Dopplers.
So then the 28 to 29 weeker, if you're doing twice weekly Doppler till ductus venosus abnormality is seen, maybe some protocol to be followed according to some. Actually, doing a Doppler ductus venosus study is technically more skilled, not available everywhere. I think people agree on that. Everybody
Ma'am,
will not
that
be.
discussion
Yeah,
is going to
that is
actually
okay.
take us to a different zone because
Okay. So then why I wanted to deliberate on truffle study is to take this directive. They have actually in the study itself the trial of randomized, this was a randomized control trial, and in that they have used computerized CTG as well to monitor the babies in this period. So computerized CTG is something which is not available in all centers.
let's make it easy
Yes.
for the audience, ma'am.
Yes, make
because
it easy.
computerized CTG is not available in India, we cannot take away from the fact that when we are pushed to the wall, we need something.
Yes.
And that something is nothing but our regular CTG, which
CTG.
we know out of our own experience as to how it functions in the preterm period.
Yes.
So if as an obstetrician you are satisfied with that and there are enough there's enough evidence of the baby growing inside, biophysical profile is good, the breathing movements of the baby are good, then
there
all
won't
together
be, Chinmay, just let me tell you, the interval is too short to pick up a growth, but biophysical profile does help even in a preterm baby, especially the amount of LICA, because oligomneos in a preterm baby is highly significant. Yeah,
perfect,
what I think absent endostolic flow is very alarming, but reversal of diastolic flow, you have to deliver the baby.
Yes.
All of you are experts in this field and you have very nice, fine points to give to the audience. My aim is to tell all the audience who understand Dopplers very well, those who doesn't understand Doppler very well, those who may not have all the experience to take things home like that, is to understand that you have a case where there is growth restriction at 28 weeks. You've established growth restriction correctly by dating and by assessing the biometry. That's very important. That cannot be absolved under any circumstances. How much ever bad antenatal scenario you have to have a method of dating the pregnancy and looking at the biometry. Now, Dopplers, as madam said, everybody may not have the technology to look at Dopplers that much. In that case, we can argue that they should not be taking care of growth restricted babies. There should be an in utero transfer.
That is not practical. That is not practical.
That is exactly why
I'm
saying
practical. Yeah.
That's true, ma'am. If it is not practical, then the entire truffle study goes to the background right there. So
that's
when
what I'm trying to tell you, Chinmay, that we cannot take the results of every study. We have to kind of,
we haven't taken
for Indian patients. Yeah.
Which is perfect. We'll reach there, ma'am. We are just at the beginning of the discussion. And as it flows, I think that message is going to be pretty clear. We can't start with a background that we are not going to follow the study, but any study which we start, we must look at the important points that we can take home. So the important points we can take home here is that simple umbilical artery Doppler is the beginning of your, when we went back to the Dopplers there, as Dr. Bela was telling us, each Doppler has its own significance. Umbilical artery is telling us placental resistance. Middle cerebral artery is telling us cerebral perfusion. And then ductus venosus is telling us oxygenation of the baby.
Yeah.
So when we are pushed to the wall at 28 weeks, we'll wait till the ductus venosus is abnormal. The question was about steroids. At 28 weeks, Dr. Bela started that I'll give steroids and then I'll start monitoring. But if you give steroids after 1 week, you have kind of lost the. So we have discussed what steroids to be given, Dr. Gauri, but could you just tell me what would be your timing of steroids? When would you like to give the steroid? Would you have given it at 28 weeks or waited till the Dopplers became worse?
waited till the Dopplers because it's the best effect is within 24 hours to 7 days. So that is going to give me the best thing, best result. And I don't want to repeat those doses again and again as far as possible.
Yeah. Perfect. Yeah.
Because repeating the dose is going to cause sometimes more harm than good. So I'm not going to keep on repeating it. So so I would prefer to be very certain that, this is my baby and I'm going to deliver. Of course, I mean, obstetrics is so much uncertainty, but yeah, we calculate it.
So when you anticipate the delivery within 1 week, you would go ahead and give the steroids. Dr. Bela, you're raising your finger.
Yes. So first thing is, number one, the progression of Doppler or deterioration of Doppler, we do not know. Sometimes there can be more deterioration even in 1 week. So if we have to deliver within 1 week or after 1 week.
We take your dilemma. It's not, I mean, what you have done is something which most of us could have done in that way. But when you have to take
so I'm just discussing the plus point of giving it. If there is a ductus venosus changes after 1 week, then we have to deliver and then we don't have time to wait for the steroids to be given.
But if there is no
I would also prefer to give steroid.
Agree to Dr. Bela, because evidence says 24 weeks onwards you should give antenatal corticosteroids.
No, ma'am. I think the message we want
that will be a wrong message to give. No.
The message we want to give is antenatal corticosteroids can optimize the outcome of a preterm birth, and the best effect is within 1 week of administration of the full course. So when you anticipate the delivery within 1 week, you can give it.
Yes.
What Dr. Bela is trying to say is, could we anticipate? No, we cannot. But that is where you have to take your clinical judgment, because this woman has been low risk. Otherwise, there have been no other factors. She's just increased resistance at this. You can just see her after a few days. Here we have put a 1 week difference because all the other parameters were intact. When it became absent diastolic flow, there is a progression towards worsening. If it was the same, you could have still waited for another 1 week and seen there. So anyway, that's a call individual people have to make at that stage, and that cannot be completely yes or no at this stage. But the message is hold on till it is inevitable to give the steroids. Dr. Niharika, are you here?
Yes, ma'am.
Yeah. So we also discussed about the role of magnesium sulfate. So what about magnesium sulfate? Do you want to start it right now?
Definitely, ma'am. See, because as soon as you're predicting that delivery is going to happen, Maxelf should be given, and Maxelf has a lot of beneficial role, especially in decreasing the reduction in the gross motor dysfunction. It works there. It works for neuroprotective role. So as soon as you feel that the delivery is going to happen within that 24 hours, Maxelf should be given. And the newer guidelines by South Australian guidelines, it just came in 2020. They say ideally 4 hours before delivery.
At least 4 hours before delivery, it should be in this system.
It will work best when given before 4 hours of delivery. And it has a lot of mechanisms in with it, which it works like. It reduces the vascular instability, it prevents hypoxic damage, it normalizes the cerebral blood flow stability, helps in a lot of ways. So Maxelf, definitely yes.
So Maxelf has to be given, and the time you start Maxelf is when you are anticipating delivery at least within 4 hours and at least within 24 hours. That's between 4 and 24 hours when you're anticipating delivery, you start off Maxelf for neuroprotection. Steroids, when you're anticipating delivery within 1 week, you give off the steroids. These are unquestionable indications. Suppose you started the Maxelf and she did not deliver, or you didn't have to deliver within 24 hours, you can stop it and then let the pregnancy continue. Those are exceptions. We are here talking about the rules. So thank you, all of you, with all your inputs. This pregnancy went on. We gave the steroids at 29 weeks, and somehow she pulled on till 31 weeks. And at 31 weeks, the ductus venosus became abnormal. And therefore, at that point, the emergency delivery was done. 1.3 kg baby boy. I will not now discuss whether we gave a rescue dose of steroids or not. But the rule says if you have given steroids and it's more than 2 weeks, then a rescue shot of steroids can be given under consultant guidance.
May I interrupt here? So you had given steroids at 29 weeks, you delivered at 31 weeks. I said 2 weeks have passed, right? So that 1 week thing is not useful. So I would, in any which case, give it at 28 weeks.
No, your point is taken, Dr. Bela. Your point is taken. The message is we need not be very liberal with our steroids very early, because there is enough evidence now to say that even 1 dose of steroids is causing some effects. I don't know what will come out of that study eventually, but there is a whole body of evidence coming on that any antenatal corticosteroid is having some effect on the neurodevelopment of the baby. So we have to be a little guarded there. As of now, what it means is let's kind of be as judicious as we can.
That is what I wanted to put in, Chinmay, here.
Yes, ma'am.
The word of caution is when there is ultrasound available for us, when there is so much of intricate guidelines for Doppler velocimetry, we should take the technology to do the interventions at the correct time and not beforehand. That is what I wanted. Yeah.
Point taken, ma'am. Now, I think Dr. Meenu, you're back with your video and audio both.
Yes.
All right. Now I need to hand over to Madam. Yeah.
Okay, so that was a very nice discussion on case 1. It is quite similar to case 1. So this is the second gravida with one para 1, living 1, 28 weeks. She comes with PIH. Previous pregnancy also she had pregnancy-induced hypertension, LSCS. In the previous pregnancy at term 37 weeks due to PIH. Now until 28 weeks everything was normal, but now she first scan, everything is fine. She has been on a low dose aspirin for her previous PIH, history of PIH. But at 28 weeks, she's come high BP and diagnosed to have on routine growth scan severe IUGR with growth along third centile and normal Dopplers. So the dates are corrected. The TIFA scan is normal previously, now severe IUGR, previous history of PIH, and now she's come in this particular visit, she's got high blood pressure. Next slide, please. Okay. So now this is similar findings, but little different. So how would you approach this case differently as compared to the previous one? What is different in this case? Because we are also dealing with maternal safety over here.
First case was also 28 weeks. This one is also 28 weeks. But first case had a normal blood pressure. This one is having hypertension. So we have to deal with her hypertensive problem, and we have to treat that as a PIH patient.
Right.
So we have to control her blood pressure. Okay. And we have to manage the blood pressure. As already Niharika has told, to use of Maxelf also. And this management of preeclampsia is very, very important to combat the early
right? And then, yes, then start her on antihypertensives. All right.
Yes. Okay. Yes.
Now the next question is, what is the role of steroid here? In this particular case, she's 28 weeks, she's severe IUGR, she's PIH. So what is the role of steroids? Are you going to give it now? Are we going to again wait for 1 week and then?
Shobha ma'am, would this encourage you to give off the steroids?
What is the blood pressure? When I say PIH, how much is the blood pressure?
Yeah. What is the maternal severity? And what is the Doppler? Doppler has not been.
And what is the urine albumin?
Yeah.
The renal function test.
Yes.
So
maternal picture and fetal is more.
So, yeah, maternal picture is severe. Maternal picture is 160 by 100 despite antihypertensives, 2+ proteinuria.
So this is
fetal picture is not that bad. Fetal picture is the same as the previous one, just umbilical resistance
is high. But then in this woman, I think
it is normal. You said.
So here the fetal condition may deteriorate suddenly.
So here,
probably steroid administration is advocated, and a lot of counseling has to go in here. And this is a ground where I think obstetricians are very justified in an iatrogenic preterm delivery. So it really gives you an edge in decision making, and it makes it easier for them to accept the preterm neonatal outcome and the NICU stay, because we have done it primarily for maternal safety and also to avoid hypoxia. So I think this is an easier management than the last case, though the mother is sicker, right? But it is a little.
So your decision for giving steroids, here you did not think that much.
Yes.
The thought which Dr. Bela had, actually in the chat box also many people have written that if you can anyway give a rescue dose of steroids, why don't you just give off the first dose?
No, I would like to say here, rescue dose has not been has not had a proven efficacy. We are not sure and we are uncertain of the harm.
I would like to add,
better to rescue the baby.
Yeah,
No,
Dr. Gauri?
I would like to add, there was an excellent talk by Dr. Basab just some time ago, where also he gave a nice, he presented a nice study where they have questioned the role of steroids at all, and whether they are causing more harm than good, and we are giving them, and we need to really probe into this. So we should be really judicious when we are using the steroid. Although Dr. Ashok ji in his talk also said that obstetricians don't give steroids so quickly and breastfeeding, but still we have to be very careful when we are giving our steroids, because it is
the debate will always exist in the intellectual level, and that will always be there in the fine print. For the bold letters, I think giving steroids is important before considering preterm delivery. Giving it at the right time is even more important. But deciding which is the right time is the biggest challenge. In the previous case, the mother had no complications. The Dopplers were just about abnormal. So we were thinking whether we can just wait. And there was a case. Here, mother is running high blood pressures. Mother is very, very unpredictable.
Yeah.
So here it makes more sense to give off that first dose, whatever it takes. So Sneha ma'am, can you just summarize the important message about the dilemmas in this case with maternal comorbidity?
Yeah, definitely, because we have here severe hypertension as well as severe IUGR. So we have two patients here to balance. But as we are the obstetrician, and in modern obstetrics, for us, maternal health, mother's life is of prior importance. But yes, of course, we have to balance mother as well as the fetus, and we have to try and take this pregnancy ahead, monitoring mother as well as fetus. So we have to have extensive discussion with the patient as well as the family for the anticipatory management, whatever we can do for them. But we have to explain them that because this is such a condition, it can progress to a severe hypertension with all the complications, and we may have to terminate this expectant management anytime. And of course, we have to keep all the facilities ready. Not that you are an obstetrician available for 24 hours, but the anesthetist, expert anesthetist, the neonatologist, which is neonatology
and the physician and the setup
unit, the blood bank, and all the intensivist physician, whatever you have, everything has to be ready at any odd hours of the day or night. You may have to go for any intensive treatment for this patient. So multidisciplinary approach is of utmost importance. And whatever the parameters where you can have this worsening of maternal condition like severe uncontrolled hypertension, eclampsia, development of all the complications of hypertensive disorders of pregnancy. So and fetal, of course, as we are already monitoring with Doppler, the worsening of the Doppler parameters can be the indication for termination of this expectant management anytime.
Ma'am, you are taking care of this patient very well. They know you from ages.
This patient needs to be admitted to the hospital.
5 minutes left.
Yeah. This patient needs to be admitted to the hospital.
And ma'am, admitted also.
Absolutely. I thought she was an admitted patient.
So she needs admission. She needs. My question is documentation important?
Very much, very much.
So whatever you are counseling has to be either video documented or written documented, because people may forget it.
And countersigned by the patient that the
I was
counseling has
talking
been
about
done.
the extensive discussion with the family. In fact, this patient has to be managed in obstetric HDU and maybe in ICU if needed. So that was
now we are also having only 5 minutes left. So let's quickly reach there. That finally all your inputs were taken. Everything was done. Luckily, we could save both the mother and the baby. But as you can see here, the reason for delivery was a sudden deterioration of the maternal condition and a very, very small baby, although extremely small, extremely preterm, too small, too early, but had to be born because you had to balance both. And luckily, this baby did well. We put this here, but sometimes we are not so lucky. So we need to be careful about that too. So we have only 5 minutes left, but we have two cases. We'll run through quickly. Minu ma'am, second case.
The third case, very quickly. She is fifth gravida, history of 4 abortions at 34 weeks with SLE. She's an IVF conception, previous 4 early trimester, first trimester.
All her first trimester screens were normal. Even
First
her uterine.
trimester Yes.
Can't hear her actually.
Chinmay, you take on. 34 weeks diagnosed to have on routine growth scan severe IUGR with growth only third centile and altered CPR. So it is a late onset IUGR. Dr. Bela Bhatt, now what are your dilemmas and how do you expect to monitor this fetus to avoid child stillbirth?
So first of all, this is 34 weeks pregnancy with late onset fetal growth restriction. Now we know the difference between early and late onset fetal growth restriction, that these late onset fetal growth restricted babies, they have very low tolerance for fetal hypoxia, and therefore they are at very high risk of sudden stillbirth. Acidosis and stillbirth. So we need to work even with subtle changes. So here the CPR is less than 5th centile at 34 weeks with a very significant history of 4 previous losses. So she doesn't have any live issue with subtle changes in the CPR. So I would give an option of delivery here because we are worried about the chance of sudden stillbirth.
You've just done the imaging now. Wait. Let it come to the obstetrician. Dr. Gauri, are you now worried about her SLE?
Well, I'm not so worried about her SLE now. I mean, of course, yes, I am worried about her SLE in terms that she could have any renal complications. We don't know what kind of organ damage she already has, whether she has hypertension or any other associated problems related to her SLE. But just now, with all her previous losses and with the picture that Dr. Bela has given us, we will think in terms of the baby and the maternal, good output that we need to give, that we will decide to deliver this patient after.
Would you want to give steroids now?
Yes, I will give steroids right away without a second thought.
It's 34 weeks. Evidence says
I will still give it to whatever benefit, because see, steroids, although she must have been on steroids because she is SLE, if she is on steroids or HCQS, but those steroids, prednisolone is different and dexamethasone and betamethasone work
very
differently.
Important point. Very important point.
Need to be given irrespective, because the effect is definitely different for both of these, and prednisolone doesn't cross the placental barrier as much as these do. So we must give the steroid dose here without a second thought, and then obviously monitor the mother and accordingly decide and plan the delivery. That is for sure.
Perfect.
Yeah. One more point, I would just like to make here is that all our cases we have been showing that our FGR baby is below the third centile. When we have a baby who's below the third centile, these are babies who are going to have a very poor prognosis or are already very much compromised, because our definition comes as below 10th centile. All our cases with Dr. Chinmay have
third centile to keep
it
centile,
where they are all pretty compromised.
I've kept it at third centile to avoid this confusion whether it is IUGR or not. It is IUGR by all definitions.
That 10th to 3rd centile, it makes a lot of difference in the outcome as well. So your decisions also should change.
When we have 5 minutes.
Sure.
Points
Next question is to Niharika. Niharika, are you there?
Yes,
she's
I'm here, right here.
Okay. So would you like to shift this patient to another unit, or would you rather deliver her at your place?
So with SLE, we have to know that SLE patients, we have 1.3-fold higher sudden fetal loss. So that has to be kept in mind at this gestation, and prolonging it obviously is not a choice here, because now baby is already at 34 weeks. Secondly, because it's severe IUGR, the baby will need a lot of help from a neonatologist. And so I would definitely like to have this baby delivered in a better care area where there are all facilities available. And my preference is always in utero transfer. I do not like to deliver and transfer the baby separately. I always like to, if possible, if rarely, if we cannot do it. And as we were talking about steroid, ma'am was saying that yes, there are two kinds of steroid, which are like non-fluorinated and fluorinated steroids. And this patient must be on non-fluorinated steroid like prednisolone, but one course of fluorinated corticosteroid should be given and it is considered safe in such cases, and which I feel should be given at this stage.
So you still want to give steroids because you think it's going to be better. Less than 36 weeks is actually what the neonatologists are happy with, because they kind of push us to take, although our obstetric guidelines have stopped at 34. There's still confusion because some guidelines say
they always want us to give steroids.
So ma'am, as soon as you ask a neonatologist, he'll say give steroids.
Give steroids. So for all practical purposes, we are still giving till about 36 weeks.
So 34 plus 6 is the guideline, but we do end up in giving till 37, and in lecture sections even later. Yeah.
because there are studies, ma'am, which say not only for lung maturity, but also to reduce the risks of NEC and other complications also reduce with this. So now again, this is a fine line, but then, yeah, I mean, it's always.
Because the neonatologist has the concept of late preterm. We say near term, they say late preterm.
Late preterm. So
They
that is why we are helped by the fact that while we are taking this decision to deliver and manage, we are including the neonatologist in that loop. So when we get his advice from his point of view, we are also covered in one way in that responsibility of giving the steroids. Till the evidence comes and till we know how much these steroids are affecting the babies, we will do whatever the consensus of our
No, it comes up. It comes up in the perinatal mortality morbidity meetings, whether which patient was given, not given. And between 34 and 37, they say late preterm. Why have you not given?
And even if we have given steroid, then the neonatologist tells us to repeat it.
Correct. So we need to have this practical approach for everything, because at the end of the day, we have to treat patients on ground. Then what comes out of that, if we can publish, we can say that this is our real problems, because we can't publish the way it goes through regular filters. We can't express our real problems.
This was good.
Well,
the woman has done well. Yeah.
This woman has done well. She had developed hypertension. And again, if you see, there was no pressing problem there, but because she had SLE, she had these 4 losses and everything put together, the consensus was to deliver her. Minu ma'am?
Yeah, sure. Go ahead.
Okay, so this outcome is done. Now this is the last case. This is again 30-weeker DCDA twins. No other significant history. First trimester screening was low risk. The TIFA was also fine, but by the time 30 weeks she comes for a scan, there is severe discordance, 80% discordance between the estimated fetal weights of both the babies. So you have 2 babies now at 30 weeks. One is growing average for gestational age. One is growing extremely small. Dr. Sneha, what are the important things what you want to know before you plan further?
It's definitely, Chinmay, because twins pregnancy per se is a high-risk pregnancy. And here you have because the chorionicity is the main thing which decides the prognosis of this pregnancy. Though all the twins pregnancies, they are prone for preterm labor and other complications. But chorionicity is the main factor which decides its prognosis as far as the outcome and the anomalies are concerned. And of course,
so at 30 weeks, Dr. Bela, you are the imaging expert at 30 weeks. Can you confirm the chorionicity for us?
No. The chorionicity is based confirmed in the first trimester, especially 11 to 13 weeks scan. The best time to
pictures. Anyone who does imaging for fetuses at any stage, the obstetrician should insist in the first trimester scan that please give me one of these pictures to tell me whether it is a dichorionic or a monochorionic.
So confirmation of chorionicity and dating, if at all you have whether both the feti are having this lower growth profile, whether it's a constitutional one or only one is growing less, that we have to decide from this. And of course, whatever we have to what is the question?
What are the important things that you'll think of? So you told us about chorionicity and about the dating issues.
Of course, Bela is here. Definitely, we can talk about discordance, because if it is dichorionic, mainly we may relax a bit apart from prematurity. But if it is monochorionic, the chance of twin-to-twin transfusion and
so that's why now we have confirmed it's dichorionic, and we are dealing only with fetal growth restriction.
Yeah. So if amongst these two, if the fetus which is having a lower estimated fetal weight, if it is less than 10 centile, or if there is a difference of less than 10% of the fetal weight, if there are difference of 18% amongst the 2 feti, then we can label this as discordance.
There are different schools of thought, ma'am. Many schools agree till 20 to 30% is what is the accepted thing. If it's more than 30%, definitely you call it discordant. More than 20% also, some of the guidelines say we can say up to 20%, we may assume it is a physiological difference between the twins. Suppose now we know it is discordant. It is more, that's why I put 80%. Nobody has a doubt in it. 80% discordance in the Varsha ma'am, what is the dilemma?
See, in the main problem is that the 2 fetuses, one is normal gestational age, one is IUGR.
So if we deliver, it will be premature or it may be IUD. So we have to balance both and have both the baby in hand. So we have to color Doppler indices will be very much important in treating this patient in taking the decision of delivering these babies. And another thing, good thing is that the DCDA, that is dichorionic. So the chorionicity is very important. So it is more assured because the Koreans are different. So that is more prognostic factor for us.
Assuring. So Shobha ma'am, you now have confirmed disparity and you have confirmed chorionicity.
Yeah.
This is dichorionic and definitely discordant.
Correct.
Now, what do you want to do here?
Yeah, there is no background risk factor in this mother for FGR is what I understand, right? There's no background risk factor. So that means that both the babies may not be equally affected. And this could be kind of inherent to the baby, which is growing less. I did not get the weights of the babies at 34 weeks.
One of them is about 1 kg, the other one is about 580 grams.
But that doesn't give us an 80% difference.
Then maybe that was 280.
That doesn't give us an 80%.
One is 1.3 and the other one is 580.
Yeah. So given this much of discordance, the counseling definitely goes towards trying to get better maturity for the better growing baby. And they must expect the demise sooner or later of the smaller grown baby. And of course, the neonatologist also has to assure them that, it is better to wait. So counseling has to be done in that direction. Also, they have to be assured, because the paramount fear in their minds is when there is demise of this baby because of the dead content inside, is the other baby going to suffer? So we have to tell them.
My question to you is, you asked me what was the percentage disparity.
Yes.
So because it was 80%, you kind of bent towards the one which is normal.
Yeah, I would like to give better maturity.
Suppose it was not 80%. Suppose it was just about 35%.
Let us go to that. Yes, let us go to
then one
that.
was 1.3 kg, the other one was 700 grams.
Yeah, in that case, I would like to wait a little while more and see whether I can get a better maturity and deliver off both of them. Because if they come to, because see, one thing, Chinmay, in the entire discussion of today, I think one thing all obstetricians should do is set up some kind of threshold of viability for their NICU and for their unit. Because we talk about in utero transfer is not possible for all our women. So many of them cannot afford care. So it's better to set up threshold of viability. So if I say that in my unit, about 34 weeks and 1.5 kg will survive well. Actually, the reality is in our hospital, 27 weeks and 750 to 800 grams, kind of we tend to go towards delivery. So in this
that's
case,
my question.
if the baby is going to make it to about 700 and 800, very important to know the pattern of growth, because IUGR decisions can't be made in one ultrasound. We have to at least, give them some interval to grow and then take a decision.
So
and
in
then,
no, ma'am, my question is, suppose in your hospital, 27 weeks, 750 grams is viable.
Yes.
Would you tend towards delivering the average for gestational age baby also, because that is a extreme prematurity you're adding to that?
So this is one situation. This is one situation where I will put the entire scene to the family and involve them also in the decision making, because they have to completely understand what are the risks of bringing up two babies and one of them being so small. For what is the affordability for two babies in NICU?
In NICU, absolutely.
They have to understand, they have to be able to afford, and let them also participate in the decision making. But some conviction has to be there in our minds for giving them some survival percentage. And for that, the NICU person has to be there.
And it's not easy, because we are assuming that the small baby, this case I put, just to make it a little simple, I put as an 80% discordance with IUD. But suppose it's not that much.
Genuine cases, so that
and then when we take it to that level, what happens is we may not be able to. There may not be an IUD, but there may be a worsening Doppler.
Yes.
And then you have delivered one baby with a very, very bad Doppler, and that has neurological sequelae. So that balance is very important. And like you said, keeping the family in the center of the
there has to be there.
Involving the neonatologist.
And Doppler studies for these IUGR with the same gusto we have to do as a singleton pregnancy, and pick up the time of the delivery of the smaller baby, just as we did in the first case. We have to pick up the time of the delivery, the time of the steroid, everything we have to do a decision making. And then once we have decided to salvage the smaller baby, we have to go forward with the same Doppler considerations which we have discussed so far, and the steroid administration and the counseling.
So steroids, Dr. Gauri, what about multiple pregnancy?
Yeah,
should we give or should we not give?
Give it. You give it.
Evidence is not so strong.
Yeah, but
I think we go by the same
still-
recommendation. Yeah,
we do give steroids
Yes,
just the same way.
same,
And
yes.
do we give double dose for twins?
No.
Single dose.
So the dose
I'm
is
sure
the
you
same.
told us to make us all laugh. Come on.
Yeah,
So sweet of you.
So the dose is the same, and
like you eat double.
timing is the same. So we don't do that because we get this question very often.
Yeah.
So Dr. Bela, now what do you want to do? She's just increased resistance in one of the umbilical arteries of the growth restricted baby. Other things normal.
So we are lucky that this is dichorionic twin, but we have to monitor the fetal growth restriction as we do in singleton pregnancy with Dopplers, uterine artery and ductus venosus. But the only thing is good if the Dopplers of the fetal growth restricted fetus doesn't deteriorate before 34 weeks. Then it will be easier for us because both of us can reach to 34 weeks of pregnancy where the chance of salvaging both would be good. But dilemma will be when if the Doppler deteriorates before 34 weeks of pregnancy, when we'll have to have a very intense counseling with the parents as to whether to deliver both the compromised babies, one premature, the other one severely affected, fetal growth restricted, hypoxic and acidotic baby. So in that case, we have to counsel that this is dichorionic pregnancy. It is better to wait further to gain further maturity for the normally growing baby. And even if there is IUD, it is not going to affect the other baby. So again, this is lots of counseling because the parents have to understand that there can be IUD with such bad Dopplers before 34 weeks of pregnancy. So all these points are to be considered as far as counseling is concerned.
It is very important counseling. If they one IUD and second, you really have to counsel them to continue with the pregnancy.
That is what they are very terrified.
Inside one is dead, so you should deliver.
The kick count will not monitor the smaller baby. I mean, separately.
It's difficult in twins. The way we use the kick count in the first in the singleton, we may not use it that effectively because you can't tell one or the other.
Yes.
Even in
Poor kick count will tell us.
One baby will be still moving.
As a ART consultant, we come across such cases in early. There is IUD of the one baby, and we continue growing the second baby only. So they accept it anyway. We have to do good counseling.
Yeah.
So
earlier in pregnancy, if single fetal demise happens earlier in pregnancy, the outcome is usually good. The dilemma is only in mid-pregnancy, like when there are threshold of viability and early prematurity. That is when the
dilemma happens. That's right. So this lady was asked to come back after 1 week, but she got caught in the lockdown and she missed her scan and then she came back again. So after 2 weeks, she has come back with an IUD of one twin. And she's now 32 weeks DCDA with an average growing fetus who has normal Dopplers. The other one has had an IUD. How do we manage now?
That's what we all were dreading. So right now at this stage, when 32 weeks with single IUD is, we have to have a close maternal surveillance as well as a fetal surveillance. So here we would like to do investigate the mother also. Plus we would like to do a very close follow-up to this fetus. And for me, I would like to make the patient understand that maybe at least prolong it for a week or so more, at least to take it up to 34 weeks if possible. But it has seen in some studies, though, you say that monochorionic twins have a higher chance of adverse outcomes, but there are still studies which do say that even in dichorionic twins, the second twin will have some kind of neurological damage if it is prolonged to a later gestation. So at present, if everything is okay with a Doppler and a biophysical profile, I would like to deliver this baby at 34 weeks if it goes okay.
How would you monitor the mother? What all are you worried about in the mother?
Coagulation profile with a CBC, complete CBC count is what I would like to do, plus a weekly Doppler for the fetus, and if possible a biophysical profile also I would like to.
You are not scared of DIC?
Yes, ma'am.
That's what the patient is going to ask. But in practice, it doesn't happen that often. So we just do a basic CBC and this. So we are finishing. So the delivery has to be delayed to at least 34 weeks of gestation. Shobha ma'am, you had some concerns here.
That's what I said, that we have to wait till 34 weeks. That was my
At least till 34 we'll wait. Now beyond 34 is again something which is questionable.
That I think has to be, it will depend on how the mother is doing, how the baby is doing. I don't think if there will be any concern about waiting later also. If everything is going well, why to interrupt the pregnancy?
Absolutely. So that's one important message which I want to pass on, that even after 34 weeks, if the parameters have, because you've done from 32 weeks to 34 weeks, the parameters have remained same, the Dopplers and the Leica of this other baby are fine, mother's blood pressures are fine, probably you could pull it more. How much surveillance, we don't know, but we have to call her, like we put a daily fetal kick count and maybe CTG every twice weekly and pull her till as much as possible. Maximum 37 weeks, not beyond 37 weeks.
36 to 37.
37 weeks.
Yeah.
So the question now is, I think all the cases that we discovered when how small is too small and how soon is too soon, is to balance these palpable risks of unnecessary prematurity versus the risk of fetal demise. Whether it is a singleton or it is a twin pregnancy, we are more or less on the same boat. In twin pregnancy, the problem is because the other baby is still there, so you need to now see if there is already a fetal demise, then it becomes a little easier for us to think. But that part where we had all the heated discussion was when one baby can be salvaged. Is it worthwhile putting the other baby at the risk of prematurity? That will depend on your own. Now, I want all our esteemed panelists to give us one take-home message each for the audience who still waited for us. I'm so grateful to all of them. So, Shobha ma'am.
Oh, it comes to me first. Yeah. Excellent panel. Chinmay, hearty congratulations to you, and of course to dear Meenu, and a lot of guidance from her, I think.
Meenu ma'am likes all the IVF related risks, so she wanted all the maternal risks to be put in.
So I have always said about preterm IUGR and deliveries that two aspects are there. One is the delivering unit should know its own strengths about establishing the threshold of viability for their own unit. That should be very clear. Today, actually, many units are enabled to take care of them. But even then, it is very important for the patient to know from the beginning what is in store. That is one thing. And the second thing is that we have to focus here on very good technology support from it to prolong pregnancy, and to get the correct time of delivery, not to be panicky about the changes that we see and deliver them early. And the third thing is, of course, the importance of counseling. That has to be perfected as an art for preterm babies. Yes. Thank you.
Thank you, ma'am. Sneha, madam. Your take-home message?
Yes, definitely. Chinmay and Meenu, hearty congratulations. Of course, as I said, in modern obstetrics, though we say mother is our priority, we can't say like a Hindi movie, we can't say sirf maa ko ya baby ko bacha sakte hai, but we have to involve the relatives in the discussion. And of course, we have to inform them everything regarding the benefits and risk of the treatment. And we have to give them informed choice of whether expectant management or intervention and their affordability as well. But we have to see that we get the optimized outcome of our treatment. Thank
you, ma'am. Dr. Varsha?
Yeah, see, everybody has the previous two one have already covered, but I would like to say the neonatologist should be also involved in having a meeting with the parents, and counseling is very much important along with the neonatologist opinion. And the babies are so precious, mother is also precious, so we have to balance when to terminate the when to deliver the patient along with this modern CTG and color Doppler indices that can tell us when to deliver the patient. And the neonatologist, the ICU, NICU care, NICU, this facility should be available because every baby is very, very precious, and mother is also very precious to get the best of everything.
Dr. Niharika?
So most of the things are covered, and I would just like to add is that we have to add a lot of TLC to this patient. So a lot of
Absolutely.
tender loving care, and we should not actually scare this patient too much. Positive vibrations and feelings towards the baby and the mother.
Absolutely. Dr. Gauri?
Since we are at the fag end of the conference, I would take this opportunity to thank Foxy, President, and all the office bearers, and especially Dr. Vaishali and her team for putting up such an excellent conference. And it has been really so informative, and it has really taken us through preterm labor so well that I think when we all go back to our clinics tomorrow, we will have good take-home messages, and it will really help us, to move towards the SDG that we have, the goals that we are trying to set for our country. And I think they have done an excellent job. I have been knowing Vaishali for her perfection and for her hard work since we have been teenagers. So I know that she would always do a great job. And coming back to our to Dr. Meenu and Chinmay, thank you for this panel and my other co-panelists. Coming to the take-home message again, since everybody has covered everything, I would just like to say that previous history taking is very important, because prevention of preterm IUGRs begins when you begin with your history and your past histories. So see that your past histories are taken very well, and there are a lot of things that you can learn from the history of the patient and from a lot of things that have happened in her past. So we really need to go into that in a very detailed fashion so that we can prevent that crossover of percentiles at a very early stage. So that is something which we should learn to intervene. Secondly, is that we should not just go by guidelines, like Dr. Shobha ma'am has said, that what is within our reach and within our centers, we should know our limitations, and accordingly we should give realistic expectations to our parents. So that would really make them completely equipped that what are they
So
going to
more practical than just theoretical ideas. Perfect. Bela madam, anything you want to contribute?
Thank you so much, Dr. Chinmay and Dr. Meenu Agrawal, for such brilliant panel, and congratulations, Dr. Vaishali, for excellent webinar and conference. So, by all the esteemed panelists have already given out very important aspects of preterm fetal growth restriction. I would just like to mention one thing, that we know that in early onset fetal growth restriction, it is a severe disease, so diagnosis is easy. Whereas in late onset fetal growth restriction, the diagnosis is difficult. So I would suggest one growth and Doppler study around 35 weeks of pregnancy to pick up this late onset fetal growth restriction, so that to prevent late stillbirths, sudden stillbirths, and which were previously put in the bracket of cause not known, unexplained. Yes, so we can pick up and prevent.
Excellent. I think most of the panelists covered everything. I think Meenu ma'am, now you need to wrap up with the final message. Dr. Meenu has been the driving force of this discussion. So let's just
Thank you, Vaishali. Thank you, Priyankar. Priyankar has done a lot of work behind the scenes. So thank you both of them. And they have done a wonderful job, wonderful conference of 2 days. Chinmay, thank you for putting up all these cases. And you are brilliant. You are brilliant as a fetal medicine.
Following you.
And you really conducted the panel very well. This was an all-femme conference, all-femme panel, all-women panel. So surprisingly, there was...
I would like to tell one last thing. In first trimester, we can detect the preeclampsia. So we have to tell we have to do the thorough first Doppler indices.
Correct. And
I think Chinmay and Meenu, the prediction of
Dr. Shobha, 1 minute. I very strongly feel that there should be a counseling subject in our medical college.
Yes.
What happens? Residents don't know how to counsel the patients and relatives. We didn't know when we were residents. So that is why the miscommunication between the patient and the doctors happen. Later on, by the time we learn, again, we are many times not counseling directly. Our residents are counseling because they are there in the hospital all the time. So I think there is a need of a good counseling training to the residents.
Yes, I fully agree. I agree with you, Meenu.
Can I interrupt here about the counseling? Yesterday, my daughter gave final MBBS paper and she had a question. How will you counsel the patient was a full question.
Wow.
The new generation is getting used to the counseling. Good.
No, they need to, because that communication is the reason why we are having all these problems between the doctors and the society.
In ART, we need to counsel a lot. So our staff is also trained for counseling.
I'd like to thank each one of the panelists and our moderators for today for such a heated and fabulous discussion at this late hour, and thank everyone who's responsible for making this conference a success. So
Well,
big
thank you. Thank you,
Kalyan.
Nitin bhai. Thank you, Vaishali. Thank you,
everybody.
Priyanko.
Thank you,
Thank you,
everybody.
Dr.
Kalyan.
Vaishali, I think
Very nice.
excellently done conference, and it was a joy to attend it. We enjoyed the whole evening.
And I
Thank
request
you.
Thank you.